thanks to every one of you that you took an effort of joining this e-conference even on the Sunday. Everyone is able to, or I'm audible to everybody? Yeah, fine. Thank you.
Yes.
Yeah, fine. This PEDIECON has been organized by My Rehab Academy. My Rehab Academy is headquartered in Bangalore and is a platform which connects physical therapy professionals, aspiring graduates, to the best of instructors, resource persons, and dignified speakers across the globe for upgrading their skills, knowledge, and the curiosity drive in their own field. In this lockdown, as every one of you know, like due to coronavirus pandemic, most of the places are under the lockdown. In this lockdown, we have become from physical to digital. As we are the startup, and this is exactly today the 6th month of our inception when we are having the pediatric e-conference. And when before the lockdown, we have been successfully doing our workshops across the country, not only in Bangalore. And after the lockdown, we have become physical to digital. And I'm proudly announcing that we have given more than 350 hours of electronic teaching to our participants till now in this lockdown. Almost 3 to 4 days a week, we have classes, we have virtual classes, of course, we have e-conference. Even yesterday, we had e-conference about shoulder rehab. 3rd May, we had e-conference about sports rehab. And dignitaries across the globe, we had more than 9 speakers who joined us. And then our participants were there from more than 30 countries. So in this less time, we have come up large and large miles. We are expecting much more. Today's PEDICON is possible, I can tell you, because of one person who has been my teacher, one of my favorite teachers in physiotherapy, Dr. Sundar Arun Kumar. His teaching has definitely changed me. And then apart from the personal, he is the person who, being a scientific coordinator, he guided us, he advised us, and today the e-conference about pediatric therapy is possible only and only because of him. So it's a great thanks to Sundar sir. Yeah, and today I'll introduce my small team also. CEO, Dr. Sumanjit Sharma. I think he's a bit busy in technical work. And Kalimullah sir, he is our CEO, and Diwakar sir, he is our CFO, as well as he is into communications. Today, all of our core members will be there with you throughout the event, and we have some common rules. So you can just see that I have typed in the chat box. So these common rules kindly follow. And our speakers are definitely way ahead people. I mean, they are not just simple therapists. They have their credentials, and their work in the society has made them, means, on such a level that they don't want any introduction. I mean, they are way ahead. So kindly listen them, learn from them. This is the opportunity in the pandemic lockdown, that we have to meet up online by keeping the law of the land. We have to abide the law of the land. And then when everything will settle down, very soon we are going to catch everyone for the physical conferences as well. PEDIECON 2020 we have started. Likewise, we have a Neuro Econ, which is coming on 28th of this month. And we have a ortho econ, we have a shoulder, we have a knee, we have a lower limb, of course, we have a back, we have, of course, pediatric today, and then sports. We are having a regular cardio econ. So these all things will be happening every year. It's not just 2020. It will be happening in 2021, 2022. So our system is in such a way that it will keep happening. So you can reach us, you can write us on myrehabacademy@gmail.com. You can see us on Facebook. You can find us on Twitter. You can actually we are found on Instagram. You can easily reach us by writing a simple mail. And then I'm telling you, our thing is like within 3 hours you give, I mean you get your uh, answer. I mean any kind of a mail if you reach us, and if you message us it is within 5 minutes. So anyway, it's a small talk about My Rehab Academy. I would like to call upon Dr. Sundar sir. Sir is there?
Yeah, I'm there.
Yeah, he's a
Yes.
scientific coordinator. I would like to invite him for inaugural note of at least 2 minutes. If he can speak something, then Sujata ma'am will start her.
Yes. Thank you, Saurabh.
Thank you, sir. Thank you so much.
On behalf of My Rehab Academy, I welcome all the delegates who are being a part of this conference. Um, uh, Starting with the program, just to give an overview of the program, I always remember this one thing. Uh, okay, I'm starting my video, right? So I was attending one of the lectures of Aina Nowak, and she says this: the most ethical thing that we can do for our children is being updated. The most ethical thing that we can do for our children that we treat in our daily caseload is trying to be updated. That is the mantra. So if we are all going to progress as a pediatric therapy community, trying to do the best of things to the children and families who are going to come to us, is trying to be at most update with what we are practicing. Um, I thank My Rehab Academy for putting up this whole show together. I think this is the first of its kind uh, among the pediatric therapists, going on an e-conference in a digital platform. I'm not sure whether somebody has done it before, but to my knowledge, I think this is first of its kind. And I'm sure that people are going to take cues looking at it, and they're going to bring much more conferences like this. Um, and then talking about today's program. Okay, the program that we have put in today. The theme, of course, you would already know that act early and treat intensively. So it's more of an early intervention based theme, and then we have really curated all the topics, and then to find speakers who have done phenomenal work in this area. Um, so most of the speakers know that today we have incredible experience. They have done some phenomenal work in what they do. So we will have the speaker introduction as we go on. This is going to be a very jam-packed learning session today. You can always put in all your queries on the chat box. There is a link that has been given to you for asking questions. So speakers would be happy to answer all your questions, or you can even go offline and speak to them if you want to know about some of the work that they're doing. And at the end, I'm not going to take much of the time. I'm going to retire now for a while, and then congratulate the My Rehab Academy for hosting a wonderful program of this magnitude. And then happy learning, everyone. Thank you.
I would like to call upon Dr. Sujata Nodana. Ma'am, are you there?
Hi, good morning. Yeah.
Yeah, Dr. Sujata Nodana. She is a neonatal and a pediatric physical therapist with 18 plus years experience. She has certified in neurodevelopmental therapy, Brazilton Newborn Behavioral Organization UK, and General Movement Assessment. She has trained in SOFI method of feeding for fragile infants and family and infant neurodevelopmental education. She is currently working in a level 3 NICU and is the director of Kids Street Pediatric Development Center. Welcome you, ma'am, and we all are going to get enlightened with your subject, what you are going to share today. Kindly, you can you can share your screen.
Okay, shall I start?
Thank you.
Hi, good morning, everybody. I'm Sujata Naruna, a neonatal and pediatric physical therapist. I work in a level 3 NICU in Mumbai, and I'm very grateful to the organizers for giving me this opportunity to speak on their platform. I hope everyone is safe at home during the current pandemic and all the chores are done so that you can sit back and relax to all the presentations that are going to happen. Now, I call my topic the third essential pillar of newborn care. I believe the first pillar would be a good obstetric care, wherein all the antenatal tests, all your medications, everything is taken care of, and it also requires a safe delivery in an institution. The second pillar of good neonatal care would be the presence of a pediatrician or neonatologist at the time of the delivery to assist and intervene as required and to ensure the safe transport of the premature infant to the NICU for neonatal care. And I call us, the rehab professionals, the third pillar because we are the keepers of the brain and we are in charge of the neurodevelopment of the child. We all know that from conception to birth, there's a lot of stress and challenges along the path. According to the World Health Organization, 15 million babies are born preterm every year, out of which 14 million survive. These 14 million babies survive because they have a good neonatal care. This decrease in mortality has come at a cost. Now there is an increase in morbidity because right now our focus is still on survival. We are more worried about whether the child will survive and how we can support them to survive. But we do not understand that these children who survive are at risk of higher developmental issues and they need developmentally supportive care in the NICU. As a therapist, it's our role to support their development and make their path as smooth as possible for their future. So, as a therapist, what is our role? We need to understand what is the role of a therapist in the NICU. What is neuroprotection and why is neuroprotection essential? What are the standardized assessments and interventions we can look at and how we can have a family integrated and care approach? We all know that when there's a sensory input, there's a behavioral response, and this behavioral response leads to other sensory input. And this entire thing is known as a sensory experience, which forms the baseline for their neurobehavioral and neurosensory development of the infant. Our preterm infants have a very altered sensory experience because they are born early, the environment given to them is very different from what they would have got in time. And this altered sensory experience leads to an altered neurobehavioral and neurosensory development. And research has shown that these premature infants are at a higher risk of developmental issues, learning disabilities, attention issues, behavioral problems, emotional regulation issues, which often lead to failures in school and compromise quality of life. And that brings us to the question that are we prepared? Are we prepared to work as a team to give these preterm infants the positive sensory experience to better their development care? And I believe for that, we need to have an open, communicative, integrated approach. The neonatologists and the professional doctors, along with the nurses and the therapists, should have an open communication among each other and involve the parents along each step of the way. As a therapist, when we should know what is the history of the child, what are the factors that we are looking at. And along with the doctors and the nurses, we have to talk to the parents and form an individualized care goal for the child to help the child in this developmental path. So if I say as a therapist, what do we do in the NICU? What is that? We all talk about early intervention. It's a very common term. We say early intervention. When we say early intervention, what do we mean by early intervention? Are we talking about intervention during discharge? Are we talking about intervention once they're diagnosed with any issues? Or are we saying that early intervention should start earlier than that? I think it's time to redefine the definition of early intervention. We should start as early as birth or admission into the NICU because we are the keepers of the brain. If we give them the developmentally supportive care from the NICU, we start the prehabilitative approach. I think it's time to change it into a prehabilitative and not keep it as a rehabilitative approach. In the NICU, our role is that to ensure neuroprotection, facilitate neurodevelopment, and nurture infant and family relationship. For that, we need to understand the theoretical frameworks in the NICU. There are three frameworks that I'm going to talk about. The first one is the Basildon's model of neurobehavioral development, in which they talk about three stages. They say that there is the first stage is the in-turning stage, which is seen in very premature infants, less than 28 weeks. These infants are very fragile, they are not stable, they are constantly in a state of sleep. They are not alert and interactive. Then is the coming out stage, which is seen in infants between 28 to 34 weeks of gestation. These infants are stable, they are able to interact for a certain little period of time. But it comes at a cost because these interactions put the stress on their system. And then there is the active reciprocity stage, which occurs at 36 weeks plus of gestation, wherein the child is physiologically stable, the child is alert, is able to interact with us in a to and fro manner. Then there is the dynamic system theory, which talks about the infant and its interaction with the environment, which leads to a behavioral response. We all know about Dr. Al's synaptic theory of development. According to Dr. Al's synaptic theory of development, all these subsystems interact with each other as when the infant is interacting with the caregiver or the environment, and we always see it in the form of behavior cues. These behavior cues can be divided into three. These are approach signs, coping signs, and stress signs. These behavior cues help us understand the child's communication. What is the child trying to show to us when we are interacting with the child? Is the child able to regulate the interaction during the interaction? Or is it stressful for the child? We all look at the traffic signal. We know that green means go, red means stop, and yellow means wait and watch. If we understand the behavior cues that the child is showing to us, we'll be able to guide the interaction and care in a supportive manner. The approach signs are also known as the positive signs. This is the ideal place for interaction, your caregiving, your feeding, your assessments, and your intervention. During this phase, the child is very relaxed, is smiling, is looking at you, and is alert. This interaction comes at a cost. If the interaction is prolonged, or if we are doing something that is going to stress the child, he may start showing us like coping signs. When I say coping signs, this is like the yellow sign. This is when the interaction is placing the stress on your subsystem. They will probably turn away, or they will brace their legs, take their hand towards their face, they may clasp their foot or their hand. This is their way of trying to regulate themselves and come back to the basic physiological level. When we see this sign, if we learn to quieten down what we're doing or to stop it for a few seconds and give them the support they need, they might come back to the basic level and we can start working again, because then they'll go back to the positive sign. If we ignore this sign, coping signs that they show us, then we reach the stress sign. A stress sign is like a complete stop. That's saying that I am completely overloaded. I do not want to interact anymore. These stress signs can be in the form of the child may start arching his trunk, he may start squirming, you will see all the limbs moving all flail or swaying around. It may come in the form of state changes, like state as in they might start crying, they might start becoming fussy, or they might just fall asleep. These interactions then continued further might lead to your physiological signs, like there will be increased heart rate, increased respiratory rate, and desaturation. As a therapist or a caregiver, we need to understand these behavior cues that the child is showing to us. Because if we understand the behavior cues, we can modify the care that we are doing and support them for their development. Once we understand these cues, we can then proceed to assessment. We all know that assessment is the baseline for all our guided care in the future. Assessments can be informal and formal. First is the informal assessment, which is what we do generally just by observing the child. Everybody knows Sherlock Holmes, the great detective, how he is to observe the surroundings and get his own interpretation and solve the case. I guess we have to be the Sherlock Holmes in the NIC for these babies. For younger infants, less than 34 weeks, we do not check actively. We just understand the environment. What is the state of the child? What is the respiratory condition of the child? How is the child's skin looking? How is the child's sleeping pattern? Is the child getting disturbed easily? What is the reaction to the night light, the sudden sound? Are there startles? Are there tremors? How is the posture of the child in sleeping? Is it flat on surface, or do you see something? How does the integrity overall look? Is the child sleeping well, or is the child getting disturbed easily? Then we check for reflexes, your rooting reflexes, your sucking reflexes, your movements, etc. We look for the tone of the child. How is the tone? Can you see a generalized hypotonia in preterm infants? And as they approach towards term, you see a change in tone. How is the child moving? Are there just random movements? Is it spontaneous? Is there a fluency or quality of movement? When the child is 34 weeks plus, then you can check the child in various positions. How is the child reacting to caregiving? When you put the child in prone, does the child turn his head? Is he able to protect his airway? Do you see reciprocal kicking? You check for the range of motions, whether the popliteal angle, whether the range of motions are proper. And all these understanding will give you a baseline of the child. How is the child doing? Where is the child on the developmental trajectory? Does the child need to be followed up? What care can we give depending on what the child is showing to us? If the child is not able to regulate, is getting disturbed easily, what can we do to modify the environment and support the child? Formal assessments are done to understand where the child is in his current motor performance. Formal assessments are standardized assessments which require training and certification. We do formal assessments to understand the child's current developmental pathway. Where is the child? Follow up regularly with that to understand whether the intervention that we are doing for the child is helping and you get a progress. Does the child need regular therapy or interventions in the NICU and post-discharge? How do we follow up with the child? Do they need to be seen by any special medical doctors? And all these data can be recorded for retrospective analysis. Formal assessments are of 4 categories: the neurological, neurobehavioral, motor, and the questionnaire for the sensory. The neurological assessment, we know one is Bechdel general movement assessment, which is a non-invasive assessment. It can be done on infants as young as 26 weeks to 20 weeks post-term age. Bechdel general movement assessment looks at the quality of movement during light sleep and when the child is quite alert and awake. We look at how the child is moving. What is the quality of movement? Is there complete movement? What is the spatial range? Is there fluency? Are all body parts involved? We look at these movement qualities and score them to help us predict whether the child is at a risk of developmental disorders or impairment. We have the Hammersmith or the Dubovitz, as it is called, which we use in the NIC, which is the Hammersmith neonatal neurological examination. It can be done on infants as young as 30 weeks to post-term 4 months of age. The Hammersmith looks at the tone, the reflexes, the movement quality, as well as the neurobehavior components of the child and the child's response to sound and light. Then we have the Previe Neuro, which was developed for very low birth weight infants at less than 1,500 grams and can be done on preemies as young as 23 weeks to 37 weeks of gestation. In the Previe Neuro, we look at 3 components: neurological, movement, and responsiveness. The first 2 components are done for all the infants, irrespective of age or they are on the ventilator or not. The third one, which is the responsiveness, you do it only for older kids who are more than 28 weeks of gestation age. Once we understand the neurological assessment, we can move to the neurobehavior assessment. The neurobehavior assessments actually give us an idea of how the child is coping with his interaction with the environment. We all know that for a sensory input that the child receives, we see her behavioral response. So the neurobehavioral assessment records all the responses in reaction to your caregiving, probably to your stimuli that you provide from the vision and the sound, and also when you move the child. We have the NBAS, which is the neurobehavioral assessment scale, developed by Dr. Brezelton, which was initially developed for infants from 36 weeks to 1 month post-term age. It was later modified to include assessments for the preterm infants and at-risk infants. It looks at the infant's ability to self-regulate and interact with the caregiver and the environment. Then we have the neurobehavioral assessment of preterm infant or the NAP. This can be done on younger infants from 32 weeks to 37 weeks of post-menstrual age. And it includes components of behavior as well as eliciting response. Now, this was developed because this can be done on a longitudinal pathway to understand how the child is responding to the environmental and the supportive care that you're giving to the child. Then we have the assessment of preterm infant behavior. Then we have the assessment of preterm infant behavior, which looks at how the child is interacting. It looks at the categories based on the synaptic theory of development, which looks at the interaction with the environment, self-regulation capacity, which affects all the other subsystems. The AFib or the assessment of preterm infant behavior requires detailed training, and it requires a lot of effort because the assessment itself takes 1 hour and your categorization and paperwork takes more than 3 hours for each infant. It's a part of your NIDCAP training. Then we have the NS or the Neonatal Network Neurobehavioral Scale, which was as a combination of all the other behavioral assessments like the NBAS, the NAPI, and the AFib. It is developed for infants as young as 30 weeks of gestation age to 48 weeks of gestation age. It describes how the child is able to cope, is able to self-regulate when stressed, when we are placing a stress on the infant during caregiving, during procedures, etc. It looks at the infant's self-regulatory capacity. Then we have the newborn behavioral observation or the NBO, which is for infants from 36 weeks to 3 months of age. Now, NBO is something which is developed for the caregivers so that they can understand their child's behavioral cues and helps develop their relationship with the infant. The naturalistic observation of newborn infants is an observational study which was developed by Dr. Als for infants who cannot tolerate touch or handling. This looks at the infant's behavioral response to routine caregiving activities, 20 minutes before, during, and 20 minutes after the caregiving. All these record the behavioral response and help us understand what the modifications do we need to do to the environment so that these behavioral responses become better. Then we have the test of infant motor performance, which looks at the motor performance of the child. It includes the postural components and the individual muscle components of the child. It can be done on infants from 34 weeks of gestational age to 4 months post-term age. And it has a good predictive value if the child is on a proper development path or at a risk of developmental issues. Then we have the infant sensory profile, which is used from birth to 6 months of age. It is a questionnaire-based method for the parents to fill out to help us understand how is the child processing the sensory inputs from the environment. Once we understand the neurological and the neurobehavioral components, then we can look at the feeding assessment. Feeding assessments are very essential because we know that the child's suck, swallow, breathe coordination matures at 36 weeks of age. But just because the child is 36 weeks of age does not mean that their coordination has improved. So before we start feeding the child, we need to check if the child is ready for feeding. We can use the NOMAS, that is the Neonatal Oral Motor Assessment Scale, the NEW, which is the Neonatal Eating Outcome Measure, and the Infant-Driven Feeding Scale to help us guide our feeding pattern. Dr. Geeta is going to talk next about the feeding assessment in detail. Once we have the assessments, we have an idea where is the child on the developmental trajectory, we can help them form a goal in conjunction with the parents and the medical profession. These goals should be supportive, which helps the child go on a proper developmental path. We all know that when the child is born early, the brain is very fragile and vulnerable. And it is critical to provide effective and consistent neuroprotective care to support optimal brain development. When we say intervention, does it mean that we just go and do something? No. In the NICU, when we talk about intervention, we talk about how do we support, how do we preserve the brain and support the development. We look at the surrounding environment. We look at ways that the child is less stressed. We look at how we can help the child self-regulate, facilitate his organization, and help him conserve his energy and sleep better. According to the developmental care model by Dr. Aldaner and Felix in 2013, we look at the 7 components of neuroprotection, out of which the first one that we look at is the healing environment. Intrauterine, the child has a very warm, cozy environment. He is in a very nice, flexed posture. He is getting his sense of smell and taste through the amniotic fluid. He is getting the sounds are reduced because of the uterine wall. He is listening to the heartbeats of the sounds of the amniotic fluid rushing around, the digestive sounds, etc. The light is very dim inside, and the touch and the movement feedback he gets to the mother's uterine and the movements of the mother. When a baby is born early, there is a different environment from what he was used to inside. This is an environment which is cold, it's too bright, there's a lot of sound, a lot of smell, and the taste. How do we protect the environment and try to simulate as much as possible that it is close to the mother's intrauterine environment? We can do that by ensuring that the lights are dimmed, the infant is placed away from the incubator, from direct light, cover the incubator. Use cyclical light so that you establish the diurnal pattern that the child would have got intrauterine. Use eye shields as necessary. If there is a light which is coming directly during procedure light, at that time cover the eyes and give the child a contained touch. How do we protect its sense of smell and taste? We all know that smell and taste go hand in hand. It gets a sense of smell and taste from the amniotic fluid, which is similar to the breast milk. And that is what gives the breast call response to newborn infants. So how do we simulate that in the NICU? We can ensure that there is no strong smell. The wipes that we use do not have a strong smell. We do not wear perfume. We can give the child a cotton pad soaked with breast milk to help him calm and regulate. We can ask the mother to keep a cloth inside her dress for some overnight and keep that cloth next to the child so that the mother's smell is maintained for the child. To encourage feeding, we can use breast milk. We can keep the cotton pad soaked with breast milk to start regulation. Encourage non-nutritive sucking. Place breast milk at the corner of the mouth so that the child develops a taste and starts the swallowing. Sucking and swallowing reflex can be done. To protect from sound, how do we do that? Sound has to be as less as possible, less than 45 decibels. In fact, for sleep, they say it should be less than 35 decibels. At no given point of time should the noise level exceed 65 decibels. Use of a sound meter in the NICU is advised. When you're talking to the child, always talk in a soft whisper. Any caregiving instruction or discussion should be done away from the incubator. The next important thing that we are going to look at is the sense of touch and movement. We all know that a child in the NICU is touched often. They have to have a lot of caregiving activities. They have to undergo a lot of painful procedures. We should try and minimize handling the child. The care should be clustered if the child can tolerate it. If the child cannot tolerate a cluster care, then we have to go for a cue-based approach. Do it when the child is awake. Do not wake up a sleeping child to do this procedure. Give positive touch. Give the child your finger to hold. Give it containment. give it proper positioning, and give it boundaries during painful procedures. Once we look at the healing environment and protect the child's environment, then we look at the other components of neuroprotection, that is position and handling. Why is positioning very important in the NICUs? Because it is important for physiological stability, maintaining the temperature, protecting the sleep, prevent adverse musculoskeletal impairment, ensure proper growth and development, also maintains the integrity of the skin, and aid with uh, regulation. How do we support positioning in the NICU? There are a lot of positioning equipments available, like the Daniel products, then the Z5. There are so many things, but in our NICU, if we do not have these positioning equipments also, we can make a nesting with the cotton bed sheets and the towels that we have. Make a thick padding. Ensure that the padding is thick at the foot end of the bed. The infant should be kept in a flexed manner, that is, hands towards the mouth or the face, hips in neutral, slightly flexed. Trunk should be slightly flexed. This positioning also helps the child modify the environment, gives it a boundary so that the neurodevelopment is taken care of, the musculoskeletal is taken care of, and also it muffles the sound and the light from the atmosphere, and it helps the child sleep better. Once the positioning is taken care of, handling should be looked into. Handle the child as less as possible. Whenever you handle the child, first talk to the child before you touch and move the child. Minimal and gentle handling is required. Move the child in small ranges of movements during caregiving activities. When you are transferring the child for KMC, bend down towards the incubator bed. Give the child a boundary with your body when you lift the child, and always maintain a close contact with your body. Do not lift the child up in the air and move for transfer care. We all understood why positioning is important, because it helps us protect sleep. And why sleep very essential is because sleep is where they restore their energy. They maintain their homeostasis, and this is where the brain development actually takes place. The plasticity and memory happens when in sleep. So how do we support sleep in the night? We already said positioning, cluster care, cue-based care, use of cyclical lights and dim lights, maintain the noise level less than 45 decibels, encourage skin to skin, and breastfeeding. At any given point of time, a preterm infant, say born at 28 weeks, through his stay in the NICU, undergoes a minimum of 500 painful stimuli and procedures. This, as research says, and we all know, this painful stimulus, which happens to the infant during the developmental part of the brain, leads to an altered sensory development. Research has shown that the long-term effects of this stress has been noted, and these children are still irritable and have regulation issues. It has a long-term effect not only on the neonate but also on the parents who are seeing their child go through always painful stress. So how do we minimize stress and pain? One, do only tests that are essential, a stepwise approach. Do only procedures that are essential for the child. If a blood test has to be done, do it only once and take the sample as it is required at once. Do not keep pricking the child. Then we look at the pharmacological management, which can be given to reduce the sensation of pain. Non-pharmacological management of pain would be via skin to skin. Ask the mother to do skin to skin during routine procedures. Breastfeeding helps them. Start non-nutritive sucking if skin to skin or breastfeeding is not possible. Swaddle the baby. Give them a flexed contained posture. Give them facilitated tapping. Use express breast milk. If the mother is not around, then the express breast milk can be used on a cotton pad to help the child calm and regulate. We all know that skin in a preterm infant is underdeveloped. The skin maturation and the layers of the skin are formed at 36 weeks of gestational age. In the premature infant, the skin is very fragile and thin. It's prone to cuts, infection, to pressure injury. It leads to loss of water and electrolytes because the skin is thin, and their temperature regulation is affected. So, how do we protect their skin and promote skin care? We have to monitor their skin regularly, check for pressure injury, keep them positioning, change positionings to avoid it. Use less harmful chemical wipes. The stronger ones can irritate their skin. If we have to use tapes to keep the IV line or the cannula in place, use small amounts of tape. When we are removing the tape, wet the tape and roll the tape and pull it parallel to the skin while holding the skin below. Always use hydrating cream and emollients as required. We all know that the infant, when it is intra-utero, is getting all the nutrition that it requires through the amniotic fluid and the umbilical. And it is in a continuous form. When the child is born, this continuous nutrition is disrupted, and they go from a continuous feeding pattern to an intermittent fasting and feeding pattern. When the child is brought to the NICU, the first priority for us is getting the child to be physiologically stable. Once the child is stable, then we start looking at feeding, because feeding and weight gain is a major criteria for discharge. How do we promote feeding? We promote feeding by giving them skin to skin. Start non-nutritive sucking at least a week prior to when you plan to start breastfeeding. Always use a cue-based approach when you're starting your feeding and during feeding. Give the child the postural support that he needs to maintain the posture so that the feeding is a positive experience and there is no loss of energy during feeding. Parents are a very integral part of the NICU. We have to have a family-centered approach. Imagine these parents had a very different dream of when they had conceived of what the pregnancy and the birth of the child would be like. And compared to that, what they got was very different. They are looking at their child in a very cold atmosphere where there is bright light, there are so many IV lines and tubes going in, and the alarms. This can be very stressful for the parents. The stress may be emotional and financial and even physical. These parents need to be counseled. They need to be given the proper supportive care. When you are talking to the parents, you have to introduce yourself, counsel them, encourage them, give them an understanding of where their child is, how you're going to support them developmentally, and help them bond with their child. We parents are very stressed and they are apprehensive about how to hold their child, how to touch their child. Start small. When the child is in the incubator and is not stable, the mother can still touch the child, keep her hand on the child, keep her finger in the child's hand so the child can grasp. Give it containment to keeping one hand on the head and one hand on the hip. These things start helping. Once the child is stable for starting KMC, you should shift to KMC. Skin to skin is a very essential component of neuroprotection and helps build the bond between the mother and the child. Skin to skin also encompasses all the 7 core principles of neuroprotective care that we talked about. It provides a healing environment. It fosters infant-family relationships. When the child is with the mother in skin to skin, there is release of oxytocin. This oxytocin release helps in the production of breast milk. This breast milk then acts as nutrition for the child. The mother's skin has the ability to regulate her temperature according to the needs of the child. So that helps in temperature regulation, helping in protecting humidity, so there is no loss of water and electrolytes. Because the mother's skin to skin and the release of the oxytocin hormones, mother is relaxed, child is relaxed, there is reduced stress and pain, the child is stable, child is able to sleep better because of the proximity to the mother and the familiarity. And the positioning and the care that the child gets in the skin to skin helps it in the neurodevelopment. Once the child is stable, feeding well, is on a good recovery path, the child is ready for discharge. So what do we do when the child is ready for discharge? We now come in to help the parents understand. We have to help the parents understand the cues of the child, involve them in routine caregiving. If the child needs any supportive care, we have to train the parents on the supportive care procedure, how to support, so that there is optimal development. Counsel them regarding the future medical and developmental concerns that you might have. Train them for the home program and advise them on the follow-up schedule. So the take-home message for us is that we are the keepers of the brain. We have to learn to observe, assess, and intervene as required. Developmental care is the third most important care pillar of the neonatal care. Ensure that the parents are always involved. Use a family-centered approach so that they have a smoother transition to home care. And how do we do that? The way forward to go is to create awareness of the role. What is our role as therapists in the NIC? We talked about early intervention. How early do we start intervening? What is the process to get trained and certified? Use standardized methods and document. Some of the ways that we can get trained and certified is through the Ignite Core and Mentorship Program, the NIDCAP, that is the Newborn Individualized Development Care and Assessment Program, and the Family and Infant Neurodevelopmental Education. These are just some of the things that are listed. There are many more resources available which you can look at. In our NICU where I work currently, we have a practice module wherein we look at all infants who come into the NICU. We assess the infants as soon as they are physiologically stable or they are for 72 hours of their birth. We do an informal assessment and prepare a developmentally supportive care program involving the parents. The children who need to be assessed further are then assessed using scales and refer to the concerned medical authority. We also teach the parents on routine care and home programs that they have to use and follow up. And regular follow-up is scheduled till the child turns 18 months of age. That's it from my end. I'm open to any questions if there are any.
Dear participants, kindly unmute yourself and ask question. Ma'am is waiting for interaction. If you want any question, kindly
Hello.
ask. Yes.
Yeah.
Yes,
Saurav sir, I have a question for ma'am.
Yeah.
Yes.
Yeah. Ma'am, am I audible to you?
Yes, yes.
Yeah. Good morning, ma'am. My name is Mithila and I'm a neurophysiotherapist. Ma'am, my question is that in NICUs, mostly physios are there for the fixed amount of time.
Yes.
Like we have a questionnaire or well-developed, a test and profiles where we can assess. Is there any profile where we can instruct the NICU nurses to be followed up? Suppose if I'm working in NICU from 9 to 4 o'clock or 5 o'clock, rest of the time, I have seen many NICU nurses like for vestibular stimulation, they do it they don't do it what is opposite to gentle. Right, they will do it very vigorously. So is there any pro forma or is there anything that where we can write it down, the program to be followed when the physiotherapist is not present in the NICU? As in how to educate the NICU nurses while we are absent over there? Okay. How to go about it? That has been a issue that I had faced when I was working in an ICU.
Yes, I understand that concern because we used to face the same. So for that, I think primarily the training has to be done. We have to train the staff on what is developmentally supportive care. Proper training and teaching them like how much movement do we have to move. Help them understand the behavior cues. Because I think when you start understanding the behavior cues, all your treatment and interventions are automatically very refined. Right. So I think training the staff. You can also look at the SENSE program by Dr. Bobby Pineda, which talks about at what age, what is the care that we have to give.
Okay, ma'am, can you repeat the name again?
SENSE, S-E-N-S-E.
S-E-N-S-E, SENSE?
SENSE program by Dr. Bobby Pineda.
Okay, fine, ma'am. All right, yeah. Thank you so much, ma'am.
Anyone else? Yeah. Anyone else can unmute and ask question?
Dr. Sujata, you can type that in the chat box, the programs, so that more people can take a note of it.
Okay, I shall do that. I think I stopped sharing the screen now.
Yes, ma'am, please.
Okay.
And your contact mail is there. Yes. Thank you.
Yes, I have given my contact mails.
Yes.
Yeah. So, program.
Someone asked a question on Infanib. So what's your take on it?
See, that is the nutrition care that we use in the NICU. I think Dr. Geeta is going to talk about it later. So I think she'll be able to address that question, please.
I think no, it's Infanib.
Infanib. Okay, Infamil is what I know. Sorry. Infanib is again an assessment that I am not very familiar with actually. I cannot see that question. Yeah.
Sense program by Dr. Bobby Pineda.
Yes.
Okay. Yeah, it has come on the chat. Yes.
Hello, ma'am.
Yes.
My name is Bhavna. I'm also a neurodevelopmental physiotherapist. I'm working with Rainbow Children's Hospital in Bangalore. So I just had a question. We are using the Hammersmith for the neonatal assessment. But I just want to know, we are doing it at term. So would you be repeating the tests on a weekly basis? Like if you're doing it at 37 weeks, do you do it on a weekly basis to check, or you just stick to a one-time assessment?
No, we do repeat the test at certain amount. So generally, I prefer a 2-week gap.
Okay.
When I do any assessment.
Okay. All right. Thank you, ma'am.
Participants, you have madam's mail, so you can write her. Thank you so much, ma'am, for your wonderful presentation.
Thank you. Thank you.
Thank you so much. So next presenter will be Dr. Geeta M. Arora. Ma'am, are you there? Listening? Yes. Yes. Yeah. So next presenter is Dr. Geeta M. Arora. She is a neonatal and pediatric occupational therapist, clinical director and founder of Move and Grow Neonatal and Pediatric Occupational Therapy Clinic in Delhi NCR, and consultant in Fortis Healthcare, Noida. She has 15 plus years of experience in the field of neonatal and pediatric occupational therapy, has training in multiple areas related to pediatric occupational therapy, with certifications in the administration of sensory integration and praxis test, sensory integration for infants and toddler, advanced research methods of qualitative assessment of general movements. She has extensive training in and certifications in pediatric feeding interventions, including SOS, feeding approach, SOFI method for fragile infants, Beckman oromotor assessment and intervention, oral placement therapy, sensory babies, assessment and intervention of high-risk infant in the NICU and transition at home. So kindly listen and learn from Dr. Geeta Arora. Welcome you, ma'am. You can start sharing your screen.
Yeah, 1 second. There's some problem in my listing. Sorry. Hi. Good afternoon, everyone. And thank you so much, my rehab conference. And I'm so grateful to be the part of this wonderful initiativeness for sharing the knowledge with you all. And I'm so much my pleasure to be here. So, um,
That's my age. I cannot put 15,000. No, you should not. You should not play like this.
hi. Um, Sorry, there were some issues in my internet. So thank you for having me here, and it's so wonderful to share with you, all of you, my little knowledge, whatsoever I learned about and practice about in ICU. So today, the topic of today is about feeding. So it's about nurturing and nourishment. So when we hear about feeding, most of us, even including me, when I'm in the position, I'll be thinking of feeding is a one vast area, and we'll be so much excited to do a lot many things. So today I'm not going to cover all the things like assessment and everything, but I'm going to talk more about like how to prevent the infant not being get hurt in the future by whatever we are doing at present in the ICU. So at the end of the presentation, you will be able to little bit understand about the basic developmental milestones of feeding, the role of therapists in the feeding in an ICU, foster infant-parent relationship, making feeding a positive experience. So when we look at the feeding is one of the very essential and very important and very complex skill, which is for all the creature in this universe. So when we look into when we are going to talk about the feeding in infants, so it is a really very complex one. It is the complexity not only ends there when the baby is going out of an ICU, it's going to be there for all through their life. So what being a therapist, what we are going to do is like what we have to do is like protect the baby, protect the infant when you're going to handle in ICU. So when we hear about feeding, we always think about something a picture like this. So you will be thinking the baby is very nicely having mother's milk or in the bottle milk, very relaxed and so regulated. And when we just imagine like that, when we just consider feeding. But when we entered into the NICU, when you look into the feeding will look like this. Some kids, they will be in the nasal tube, some will be in the bottle fed, and they'll be having lot of tubes, and they will be CPAP and lot many complications you'll be seeing. So that makes more complex when you're just going for feeding. But feeding is one of the challenging tasks, and it is the dynamic relationship between the parents and the caregivers. The present experience, what they get in the NICU, is the foundation for the future feeding skills. That means, so what the kids may be having a lot of unpleasant experience, like they need, like Dr. Sujata spoke just now about uh, the noise, the touch, the smell, and all these things will impact on the child's immature brain. That will have a major effect. When we come into the feeding, so the nasal tubes and a lot of suctioning, it gives a lot of aversion, it gives a lot of tactile aversion. So these kids, a lot of studies are saying that these kids, when they grow up, the parents report they have so much of feeding difficulties. So it is lifelong. And one more thing, very important thing, is like the bondage between the parents and the infant. When the baby is in the NICU, many of the times the mother is outside, the father is outside, the mama does not know what is happening inside. They are not allowed inside to see what's happening. Being a mother, she will feel so depressed and stressed. What's happening? Like the bonding happens, the oxytocin happens only by looking at you, holding the baby. It happens through that. So when the initial stage, if there is an interruption in the bonding, there will be stress, and it is going to impact the child forever. So feeding, again, is a developmental process. It's an interplay between the maturation and experience. The positive experience support skill development. So what's our positive experiences? By understanding the cues, by handling them nicely, by giving the lot of neuroprotective things. All these things will give the baby to develop the skill development. Once the skill development is there will be a lot of efficiency to do feeding. And if there is efficiency, automatically there will be endurance. Again, the family is the most important and consistent context in which the baby develops. We already seen this thing. So what are the modes the neonatal nutrition happens? Like through the parental nutrition, that is the breast milk, nasogastric tube, orogastric tube, transfloric tube, gastrotomy tube, and overfeeding. The reasons why they come to what are the referrals when the infants come to for feeding therapy. So the infants who are less than 1,500 grams or less than 32-week gestation, intubated more than 48 hours, multiple intubation attempts, and cleft palate and structural anomalies. So what is the impact of the NICU setting? In the premature baby, the babies in the NICU babies, the premature kids, infants' brain is very immature. They're very fragile. They have the very fragile, immature physiological systems and sensory systems, and their pathways are still developing. So any stress during that time will lead to major problem. Any stress during feeding during that time, it leads to major problem when they grow up. So the negative experience have a maladaptive feeding behavior and feeding refusals when they grow up. Effect after NICU is a long-term process feeding problem. When you just listen, when the kids grow up, a lot of parents, they say that my child is a picky eater, my child don't eat all type of food, my child have this problem, that problem. All these kids, when in my clinical experience, when you just ask to the history to the parents, oh, they will be saying, yes, my child have been in the NICU for 1 week, they were having this problem. He was a premature baby. So when they grew up, and most of the time, what happens is like in NICU babies, when they go out from the hospital to home, the home transition, what happens is like, we always emphasize to the parents about having more intake. We want the baby to gain weight. So the mama also, she worked more hard. There was a study in 2015, which says like they have taken at premature infants, they have taken some 70 kids who have just been infants. They have in a questionnaire type research where after 2 and 7 years, they have did the same questionnaires they used. So they found that the outcome is like those kids who were in ICU, they have very much of feeding difficulties, and they have major family issues which is happening related to the kids' health. So feeding can be stressful for the parents, as I said, because they become very anxious. They become very anxious when they come. The mother will be very anxious when the child is not able to, when she is not able to feed the baby, when she is not able to breastfeed, when she is not able to hold the baby to feed the milk, and they will be very anxious. They will be very depressed, and there will be a lot of autonomy. They don't have the power to feed their baby, and they will be lack of continuity of approach. For an example, when the child is in the NICU, there will be a lot of shifts and all will be there. There will be certain nurse and therapists, they will be talking to their parents, parents about their feeding, about the baby and all. So when they due to their shifts and all, most of the time there will be a lack of communication happens, and there will lack of confidence also happens in their feeding experience for the infants, to the parents. So what's the feeding culture? What is the feeding culture in our, let's talk about our country and most of the many other countries. We always, honestly speaking, we always consider about the volume. We don't think about the quality. We don't think about, sometimes we don't consider, we miss, it's not like we don't consider it, like we miss to consider about the feeding skills, which is very essential. We always think about how much my baby is taking the milk, how many frequencies, how many ml I have to feed the baby. And have we ever seen whether the child is able to suck, whether the child is able to swallow, my child is able to breathe during that suck, swallow, breathe pattern, whether my child show any signs, stress signs during the feeding. So we always think of, because we think, and it's a reality also, we think about the child's weight, the child's survival rate actually. So we miss it. So we forget it's going to have impact on the child. So most of the NICU here have volume-driven culture. So our aim to being here is like how to help a child to experience a positive experience during feeding. Even when they communicate, these children, they communicate to us. The preemies, they try to tell us communication, how they are tolerating the feeding. They, through the signs of engagement, I want to continue and I'm okay, by showing they're holding their hands together in the midline, and they're holding the, putting their fingers in the mouth, or trying to put it towards the bottle, or holding the mother. All these things are the signs of engagement. And there are the signs of disengagement. I'm done, I need to rest, like Dr. Sujata told very nicely about it. Like they're saying, their stress signs, like going away, flaying of the hands, their raised eyebrows, skin coloration, discoloration, and all these things you really have to notice. They always communicate to us, infant communicate to us so nicely, and we adults sometimes we miss to understand the cues, what they tell to us. All we want is just to put the milk inside and done. So what do we think about this? Let's have a reflection. Are we really looking about the nourishment or nurturing? So most of the time we just look into the nourishment, and nurture, sometimes we miss it. So what is our role here? The reason I present over here today is like, we have to really concentrate on how to nurture the infant, how to nurture along with the nourishment. It is also very go hand in, it should go hand in hand for a child to function better way. As being a therapist, like we know many of the times we seen the children who come to us, like the premature children, the babies who had a lot of any congenital issues, they're having any other for any other reasons they got admitted in an ICU, neurological issues. All these children, they will be the parents, they will, most of the time they don't get aware. And after 2 years or 3 years, they come to us and they will say that my child is not eating, my child is not doing, my child, there is a lot of problems, sensory processing difficulties. Because when you just look into this, when you look into the studies, they say that a lot of sensory processing difficulties, children who had the experience of an ICU, especially they have a very bad tactile input, they have very bad aversiveness towards tactile input, and their overfeeding also, and they smell olfactory also. They all have the impact when they grow up and they come to us with. So our aim is to provide the nourishment and nurturing together to bring the betterment of the child. Prevention is better than cure always. We have to keep in mind about that. What do we think? What are our perspectives related to infant feeding? Are we improving infant feeding? Improving infant skills? I think we usually do infant feeding, but now we have to work more on the infant skills. Are we looking at the quantity or quality? Do we observe understanding the infant's cues before feeding? Many of the times, no, because we may think the baby, for an example, when you go to the NICU, we may think like the baby is, when you put something in a mouth and using your nipple or pacifier, the child may not be ready, the child may showing the stress signs and everything. But the moment you just put a finger, or the moment you put anything in the mouth, the child started to suck, because of the reflex. But we sometimes misinterpret, and some of the times we have been told that's okay, they will pick up, that's okay, they will pick up. It's not about picking up, it's about, we are stressing the child very badly. Whatsoever he is doing is, that's a reflex, the sucking is a reflex, it's not sucking the skill. So we have to be very careful, and we have to understand about this thing very carefully. So what is the role as a neonatal therapist here, as a PT, OT, or speech therapist? Our role in supporting transition to oral feeding. These children who are in NICU, they're premature children, they're mostly on the tube feeding. Our main role is not to go jump into, I'm going to do this thing. I'm not telling, I did this mistake around 12 years before, when I first entered into an ICU. I got so excited, and it's not that we just want to harm the baby. It is that we are so excited that we got an opportunity to save somebody. We got an opportunity to do something nice for a baby. We can rehabilitate, we help the baby. That's our intention. So unknowingly, we just do a lot of things, touching, holding. We do a lot of range of motion. We do a lot of oral stimulation. Many of the times we get a lot of sensory input, like some people used to say that, like they used to sound, they used to do a lot of the smell, and many of the things. All these things will affect the baby. You put the finger in the mouth and the baby is sleeping, the baby is lying down or sleeping, poking the finger or poking the nipple into the lips, and then putting it towards the corner of the lips. All these things are very, 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 it's we should not do that thing, because that's going to harm our baby. Because their brain is not matured enough to handle the stress given by the sensory input whatsoever we are doing. So never, our role is to protect the whole experience. Our role is to protect the sleep, to brain development and growth during the handling, helping the parents to understand how to hold the baby, how to handle the baby when they are feeding, how to do gangrene care. That is very important. Skin to skin touch, that's very important. That gives a lot of, improve a lot of weight, and the baby will able to give a lot of milk also later on. And supporting non-nutritive sucking. Non-nutritive sucking, we can use the pacifiers. Using the pacifiers, we use non-nutritive sucking. And that's very important. That is for beginning for the feeding. We make the baby to ready for the feeding by giving the non-nutritive sucking for a particular time. Taste introduction, that means like using the mama's milk. We will be using the taste introduction. Mama's milk or in the nipple or through the finger. We'll be just doing that. And then when we're coming for the staff, family and staff education guidance, we have to educate the family. We have to educate. It's a collaboration between the nurse, neonatologist, and the therapist. We all have to work hand in hand. We really have to work very closely with a nurse, because being a therapist, we go once in a while. We go in a day. We go for an hour. Or weekly twice or thrice or something. It depends on the hospital, or it depends on the therapist. But 24 hours nurse are the one who is there going to be with the baby. So it is very important to have a very good collaboration with the nurse to understand how the baby does. How have we tried this positioning? How was the baby's response for it? How was the sleep? So all this thing will give a very good knowledge about the baby, and we can share the knowledge whatsoever we learn new, and we can share. That helps. It's a guidance for the staff members, as well as the family education is very important, and making the parents to understand what's going to happen to the baby, how we can handle, how to handle the stress, how to go for a gangrene care, how to go for the feeding, how to work on the pre-feeding skills, and there's ongoing recommendation and side-by-side guidance all the time. So we all know about, we use a lot of theoretical framework. We use a lot of dynamic system theory, attachment theory, and family-centered care and synaptic theory. Dynamic system theory is mostly about, focuses on the family and home environment, and ICU environment, and neonatal functional activities. Attachment theory, it's a bond between an infant and the caregiver, usually the mama. And the family-centered care is the family and caregiver in the center, and we all work together. And synaptic theory of development is what we all work along. It's very important. Everything is very important, but what's our treatment protocol, positioning, everything, this theory is the base of whatsoever we are doing in an ICU. It's proposed by Dr. Els in 1986, sorry if I'm wrong. It's proposed by Dr. Els in developmental process are based on the neurodevelopmental subsystem interaction with neonates, internal functioning, and environment, and caregiving. So this behavioral observation based upon the synaptic theory of development, dynamic interaction of four behavioral subsystems. Infant communicate to us through signs of stress or stability. Our interaction with the baby may disrupt the subsystem. The goal is to support the organization and infant's natural development trajectory. This is a study done by Svenny and Dr. Els in 1986. There are five subsystems. As we know, there's autonomic, motor, state, attention, interactive, and self-regulation. These all work hand in hand, and it all it all interlinked, and we all work. We have the baby will be showing the cues. We will be. It's interlinked between everything: the baby, the environment, the caretakers, and we have to understand the stress. We have to understand the positive cues. So to facilitate the child's development. As we know, we have reflexes. The rooting, sucking, swallow, and tongue press reflexes are the one which forms in the utero. Gag forms in the utero. The other reflexes which we have to know about is transverse tongue and palmar reflex and phasic bite, ATNR, STNR, palmomental, and tonic labyrinthine. So fetal development, when fetal development is very important to understand, as it is continuum of skills which we observe in preterm. So as a therapist, it's very important for us to understand about the fetal development. Without not understanding, it is very hard for us to doing many protection for the child. It's very difficult. So gestational development of the oral feeding skills, 16 to 17 weeks, swallowing regulates amniotic fluids, 23 weeks. There's a practicing breathing by inhaling amniotic fluid by 28 weeks, rooting, sucking, swallowing, and reflexes present. By 32 weeks, gag reflex and non-nutritive suck present. By 34 weeks, there's a functional suck, swallow, breathe pattern, but poor endurance. By 36 weeks, there is a coordination of suck, swallow. And sucking, when you're coming for sucking plays a keynote in the life of very young infants. Not only for the primary means of receiving nutrition, but it is the one which it is the thing which helps for calming and pacification. When the baby take their hands towards the mouth and they put the fingers in the mouth, they go for self-regulation. It happens because of sucking. It is an initial method of exploring the environment. They put the finger, they put amniotic fluid inside. They suck, they put everything in the mouth, they suck, and that is exploration for exploring the environment. Unfortunately, our preemies have difficulty in sucking. So when we look into the milestones, when we look into the physiological development, the developmental things, the children who born early, they will not be having the sucking pad, because the sucking pad develops at the end of the and during the end of the pregnancy. That's your final month. So the children who born prematurely, they will be not have the sucking pad. So what is the role of sucking pad? Sucking pad is a one which helps for your placing the tongue on the gum. It helps for your sucking. It helps for your intra or pressure, which is important for sucking. And it is where it's not there, and the baby means the child will not be able to do sucking. So this sucking pad will not develop after birth. And for the children who is born near to term, for them the sucking pad will be thin. So that's also a reason our children, they struggle for sucking pad. Just imagine the children, look at the infants, like the preemies, they are not having the sucking pad, but still they struggle to just handle, and look at the stress whatsoever. Look at the stress level they will be having and the impact what they undergo. So we should be aware of this thing, sucking pad, and is the one which helps for all those things. And then when you're looking at the development of the sucking, swallowing, breathing, as we think about neurodevelopment in this pattern, babies start with the sucking, swallowing as early as 12 to 13 weeks in their womb, and sucking and swallowing of the amniotic fluid and putting the fingers in their mouth takes place. By 32 to 33 weeks, there will be rhythmic sucking and swallowing. This is a start for the feeding skills. By 34 weeks, there is a dyadic sequence of suck and swallow. And it is the cornerstone age for some. You need to start with the feeding at 34-week gestation age. At 34-week gestation age, there is a great start. However, really, it should be efficient eater or feeder and good eater. You need to have a skill called suck, swallow, breathe. So the sucking, swallowing, breathing, it develops only by 40 weeks. So unfortunately, that's going to be a problem for our children. So imagine the children, when we are just trying to make the children to have their milk by 34, 36 weeks, the breathing pattern have not get matured because of the respiratory system, respiratory center. So on that time, what happens is like the child again struggle to pick up that thing till suck, swallow, breathe, suck, swallow, breathe. So all the time at 36 weeks, it will be like suck, swallow, suck swallow. By 36 weeks, it will be suck swallow breathe by 40 weeks. So the children who are by 36 weeks, they're really struggling to go for that coordination. So when we're coming for development suck swallow breathe, the maturation of suck swallow and breathe coordination reflects a predictable pattern of time neurodevelopment. This, I think we know, there will be, if there is a poor suck swallow and breathe disorganized sucking patterns, there will be disorganized sucking patterns, which leads to fluid threats to the airway, reduced rate and depth of breathing, and extended airway closure, and they'll be unable to self-regulate. If the child have difficulty in suck swallow breathe, they will be having a lot of difficulty in self-regulation. So self-regulation is very important for almost all of the things whatsoever we do in our life. It's same for the infants also. What is the need for oral feeding success? It's the ability to read infant behavior, competent feeding skills in reinforcement of pleasurable human contact, and support of infant's own pace. So this is some readiness skills criteria for NIC readiness criteria, where autonomic, motor state, and attention interactions. And then in this thing, the steady breathing, heart rate, we have in autonomic, we have to see whether how is this, the breathing, the heart rate, oxygen saturation when held, and rooting hands to mouth, wake on quite alert, engaging in care and shifts gaze towards the caregiver. How is the breathing again? We have to check sucking on hands or pacifiers. Awakes 50% of the caregiving times and stays awake 5 to 10 minutes. And how is the energy observed? So again, we'll be just looking at the same breathing and active tucking of the arms and legs. These are the 4 things which we have to see before we are going for feeding skills. The breathing is very important. So in an infant's, breathing and in feeding plays a major role. If there is issues in the breathing, so for an example, if the child is having difficulty in doing suck swallow and breathing, if the child is facing stress during that time, automatically that is going to affect the respiration. So when it's going to be a problem, the respiration, automatically it leads to the baby to stay in the NICU for quite a longer time. So we really have to respect the child's cues while we are feeding the child. The most important to assess during a feeding, most of the baby does during feeding is related to airway maintenance, stop sucking to breathe, and stop soon enough. How to recognize and interrupt signs of stress during a feeding? It's all related to the respiratory. So extended airway closure, when there is extended airway closure, the baby will be showing pulling away, fling a fingers place, extended arms, pushing nipple, eyebrow raise, eyelid flutter, and fluid and gaze aversion and flailing. Fluid threats to the airway, drooling, there will be a lot of drooling. That leads to self-aspiration, drooling, aspiration leads to that. Hard swallowing, wet breathing, multiple swallows, stuttering, alping, gulping, coughing, nasal congestion. Reduced rate and depth of breathing, increased WOB, head bobbing, head back, stutter, grunting, color change, and nasal fraying. These are the signs which will be showing when the baby will be showing the stress, the baby is having problem in the respiratory system, and if the baby is in stress during the feeding, we're going to start the feeding. So let's look into this picture. So we may look into the picture that the baby, the kids are having, the caregivers are giving the milk to the baby, but look at this picture. The baby is having milk, but look into the eyes and look how their caretaker, how the caretaker is holding the hand. How is the position? It's comfortable, it's appropriate position. No, it's not appropriate position. Sorry, it's not appropriate position. And when you look at the baby's hand, how they are going to stress and on the stress hand, and look at the baby's arch in the second picture, and look at the picture how the caretaker is taking the baby just body away. They have to always bring the baby near to the close to the body to help to giving the boundaries which help them to self-regulate when they're going to feed. Look in this picture. Look at the, even though we may think the baby is holding the baby is holding the bottle, but look into his eyes. He's happy? No, the baby is not happy. The child is showing the stress signs. So we may think the baby is having milk. Either in many of the hospitals, we don't use this bottle. We'll be using Pallade. And we have to really see what is the stress signs, like what is that? What is it? Sometimes they go like this, sometimes they go like this, sometimes their skin color, sometimes we have to always look at the eyebrows. That's very important signs they show during the feeding. So this is the sort of regulator. Look at the baby. There is some co-regulation between the mother, the caretaker mother, and the baby when they're looking into the eyes. And look at the baby, how the breastfeeding also. It should be like this. The baby should be having milk like this. We have to encourage. This is a positive experience. We should provide a positive experience like this. So effect of infant feeding, and all of the systems go hand in hand, like a physiological, motor, and parental attribution, and your organization abilities and self-control behavior, all these things as per Wolf Glass in 1992. She said all these things have to go hand in hand for effective feeding. So when we come into feeding, so there are two types. There's task-oriented feeding and infant-led feeding. The task-oriented feeding are the one we focus mostly on acquisition of all feeding. That's the greater volume transfers. How much milk we are giving, how many times we are giving. And they talk about the oral stimulation, ATVV, and it's sensory stimulation and entrain and pulse and visual vitals based. Vital based is the one they give us input, electrical input in the baby's mouth for feeding. So infant-led feedings focuses on improved physiological, motor, behavioral state stability, gestational age at full oral feedings, a length of stay. Example of this thing is cue-based feeding and infant-driven feeding. So when the infant is perceived as having meaningful behavior, that is communicative intent, the focus changes from the volume-driven to the co-regulator approach, through which the infant guides the caregiver. This is a cue-based feeding. So the cue-based feeding is always very important comparing to your task-oriented feeding, because the task-oriented feeding, the baby will be having a lot of stress. We will be, most of the time will concentrate only on volume. The cue-based feeding and infant-based feeding refers to feeding effort based upon the cues or stop based upon the cues. The caregiver is making decision and changing the support and interaction based upon the behaviors of the infant. It's an ongoing process. The infant-led feeding impulse that infant is setting their own schedule of feeding as they become capable of doing it. For example, when to start oral feeding in many cases rather than being offered on a scheduled time. So let's go for the feeding assessment, differential diagnosis and observational and hands-on. In differential, we'll be gathering the clinical data, thorough review of comorbidities, and family involvement history, and observation hands-on, physiological stability, general motoric function, state organization, oral structure function, and feeding function. These are the things which we do. There's something called formal assessment. The formal assessment we do no mass. It is a 2-minute assessment, which is widely used all over the world. It's a very famous assessment tool, which is newborns and for the tube-fed preterm babies also they use this thing. And then early feeding assessment. It is from the infant through the 6 months, and SOFI methods, the support of oral feeding for fragile infants. It's used for the tube feeding also. They will be having logarithm for this thing. It's one of the very wonderful wonderful method. Infant-driven feeding assessment it helps about the readiness, understand the readiness, quality, and caregiving techniques. And NEO is the assessment tool, which is done by 30 to 32 weeks PMA until 44 to 6 weeks corrected. Neonatal eating outcome scale, we will be assessing the pre-feeding skills, all feeding skills, and observation at the end of the feeding. These are the formal assessment skills we use mostly. Why is infant, so when you're before going for feeding, before going for the intervention, we have to understand why feeding readiness is important. Allows the infant to drive the feeding process. The evidence supports quicker time to full oral feeding cannot speed up the maturation, but we support it. The factor related to readiness, medical stability, stable and appropriate respiration, oxygen saturation, sustained alertness, and oral responsiveness may be rooting, but definitely not sucking. Pre-feeding readiness. The baby should be alert, awake, calm, active rooting reflex, and active sucking on pacifier. Oral pharyngeal reflexes, strong and coordinated non-nutritive suck, demonstrate hunger signals, tolerance, handlings, and holdings, stable medical status, tolerance, handling, and holding, breathing, comfortably respiratory rate of 60 to 70. Positive feeding experience, why it is so important, because early feeding experience in NICU can potentially impact and families' relationship with feeding far beyond discharge. Although less than 1% of the premature infants require supplementary feeding at times of discharge, over 50% parents report problematic feeding behavior at uh, 18 to 24 months. There's other studies as the parents of NIC graduates reported disorganized feeding, including coughing, vomiting, feeding refusal in 29% at 6 months and 37% at 12 months. So to prevent all these things, early feeding experience in ICU is very, very, very important. To avoid this, transition to exclusive overfeeding into the preterm infants. So now we'll be looking into the nutritive sucking and not nutritive sucking. And non-nutritive sucking is very important before we are starting for the nutritive sucking, which helps the baby to, that's one of the pre-feeding readiness thing which will be given to the baby. So what are the characteristics of the nutritive sucking?
Hello, Geeta ma'am. Sorry to interrupt you, but can you please be a little more loud?
Yes, sure.
Not so very, or maybe closer to the microphone. Yeah, sure. I'm so sorry.
I'm so sorry. I'll do it. So characteristics of, is it okay?
Yeah, this should be okay. Yeah, this is fine.
I'm sorry. When we're looking into characteristics of nutritive sucking, suck, swallow, breathe, burst patterns, how many suck, swallow, breath sequence an infant takes prior to taking a longer breathing break? Immature, 3 to 5 suck, swallow, breathe sequence, and transitional 5 to 7 suck, swallow, breathing sequence, and mature 10 to 20 suck, swallow, breathing sequence. So successful bottle breastfeeding, we have to focus on quality, not on the quantity. That's very essential. Breastfeeding positions, the cradle, cross cradle, football, and lying down. Supporting breastfeeding. Skin to skin holding, non-nutritive nuzzling at pump breast, and progress based upon the infant's cues. The preem is not expected to breast and bottle the same feeding supplement with the tube feeding. Complete source of nutrition for the infants and is digested more easily than any formula milk, decrease incidence and severity of respiratory infections and respiratory stress syndrome and gastroenteritis and ear infections. So ear infection is one of the main things we have to consider when we are giving the breastfeeding and the bottle feeding babies when they discharge for NIC also. So when we are doing breastfeeding, as we know, many of these NICU kids, they tend to get the ear infection. One of the reasons is like the positioning. So many of the times the parents unknowingly, they make the baby to tilt the head a little bit backward while they on a vertical position, not in an appropriate way, not towards the chest, not in a sideline position. In the infant, what happens, we have the essution tube, which is going towards here. It will be horizontal comparing to the grown-up people like us. So when the baby is having the milk in a vertical way, and what happens is like this fluid will go inside this tube and leave and go and fill the middle ear. So that leads to most of the children, they will be having the premature children. One of the reasons for the ear infection, deafness is this middle ear infection, which leads to the hearing loss. So we really have to encourage the parents to go for the proper positioning, whether it's feeding in the breast, through the breast, or in the bottle feeding, or when you're doing palada also, we really have to, palada is a thing which we usually widely we use in our country in a traditional way. It's a cultural way we use this thing. So even though we have a lot of sensory impact in that thing, because there's a lot of differences between nipple and the palada. Palada is a steel, it's a metal, and nipple is a skin, is a soft muscles. So when a child who is not ready when the immature brain is facing this type of sensory input into their mouth, understand the stress, what they will be having. We may think the baby is, we're just pouring the milk. We may think the baby is having the milk, but the baby is not having, just pouring the milk. We cannot suck a metal. We have to understand that thing. So we really have to encourage them in breastfeeding as early as possible. So when we're coming for acquisition of oral feeding skills, the baby regulated organization of subsystems and sucking, there are 8 steps along with a pure feeding continuum. It was by Bronze and Rose, who's one for Sophie method. In this acquisition of all feeding skills, there are 8 steps of stability with handling and carrying, stability with being held, stability while in arm and with a pacifier, obligatory, alternating the position, intermittent, how intermittently you're giving the milk, and then how coordination, the coordination is about your suck, swallow, and breathing, and how integrated, how is the self-regulations. So we have to consider all these 8 steps while we're feeding the infant. So therapeutic intervention during the feeding, we taste via the pacifiers. Swaddling is one of the techniques. We use elevated side-lying positioning and slowing the flow and pacing, chin cheek support we have to give in a gentle way, not very hard way, like we should not do it. Just we have to give it very, very, very gently along with your positioning toward a baby towards your body. Pacing. Okay. Pacing is other thing we'll be using for a lot of flow, especially in the feeding in the bottle. And the breastfeeding also. Strategies to optimize all feeding. Provides the positive pre-feeding experiences, includes family and feeding, providing opportunity for breastfeeding at each stage, and creating the slow flow with appropriate posture, support, and pacing as needed. Flow infants cues for starting and stopping the feedings. And success should be defined in terms of quality rather than in terms of volume or age of acquisition, helping parents feel comfortable and confident in feeding their infants. So what are some activities we support the feeding readiness? Skin to skin with the mother, father, pleasant stimulation to face and mouth, and whole infant during oral stimulation, whole infant during the tube feeding. Always, when you're going to touch the baby, always talk. Always talk. I think Dr. Sujata had mentioned about it. Before touching the baby, always talk to the baby slowly, not so loudly. And before touching, you always make this. Inform the baby that I'm going to touch you by talking. And non-nutritive sucking on pacifier or breast, pacifier dipped in milk, care during suction. And oral motor control, we have to understand about the anatomy of the mouth, cheeks, tongue, palate, and size of the oral cavity, which is very important for a pre-feeding feeding skills. It's very important. And stability in general body and head. And we have to always look into the postural stability of the baby's body, because we cannot, we see in the other picture, like we cannot make the baby to go back and then feeding the baby or holding the baby in upright position. All these things are going to be very harmful for the baby. The impact of flow on the feeding, the higher the flow, more challenge for the suck swallow breathe. So when we are doing any form of feeding, even breastfeeding also, we have to understand what is the flow, because the children, they will not be able to, the fragile infants, especially whose the suck swallow breathe system is not so much developed, it's not so much mature, they'll be having difficulty in this process. That leads to the aspiration. When they're not able to control, that leads to aspiration. That will give a severe damage to the baby. Increase the likelihood of a physiological compromise, which leads to increased fatigue. High flow puts on infant at risk for aspiration, even if swallow integrity is normal. Low flow allows much more time for breathing and feeding in a comfortable manner. It's something of a basic technique, so which we use mostly usually for the mainly for the bottle feed, and we can use it for the breastfeeding also. For the breastfeeding, what we have to do is, like, we have to make the baby close to the nipple, but at the same time, when you feel that it's overflowing, the baby is not able to drink the milk, so we slowly take the upper lips from the nipple and let the baby just have been in touch with the lower lip, your nipple. The baby have to touch a nipple through the lower. We should not suddenly take the baby out from the nipple, because that will make the baby to go for dysregulation. So we have to be very careful when pacing, when giving the pacing to the baby using during the breastfeeding. So it helps in the endurance and safety and encouraging positive stress-free free feeding skills development. Fostering the co-regulating feeding, a foundation for a strong parent-infant attachment, co-regulated feeding, with the infant as active participant in feeding. Use the caregivers, especially the parent, as a partner in feeding, values the perspective of the infant. So a lot of NIs units are there. Using a pacifier will have a negative impact on breastfeeding. So no, it is not that. We have to use a pacifier. It's non-nutritive sucking. It helps the baby to go for self-regulation. Also, it helps the baby for future sucking. So sucking on a pacifier before feeding will tire the baby body out. No nutritive sucking wears of, no, it will not wear on the baby. Slow flow nipples wear babies out and make it harder to progress. No, when the baby is having very fragile suck, swallow, breathe, and mouth oral control and a tongue control, trunk movement, these children will have a lot of problem in swallowing. So when the problem in swallowing is there, the baby will be having difficulty when you just give the bigger hole or wide hole nipple. So the baby will just go for aspiration again. So this is the stage by Nan, one of the by Nan is a nursing or nursing association for the neonates. They have said like pre-feeding stage. It comes in the pre-feeding stage. We'll be talking about the non-nutritive sucking and opportunities and oral pre-oral stimulations and colostrum applications to the mouth tissues and lactation specialist consultations. And initiation of the oral feeding is like, is the infant is off ventilator or without other contraindications of feeding, is infant able to maintain the physiological stability with routine care, if the infant is able to demonstrate the behavioral organizations with routine care. And when you're coming for oral feeding readiness, it's attempt of breastfeeding one or two times daily, reduce the number of oral feeding attempts if physiological or neurobehavioral instability during feeding. Then when you're coming for the advanced oral feeding supportedness, ongoing feeding assessment and monitoring of the weight gain if the physiological and behavioral stability with oral feeding are appropriate growth and trend. The consider involvement of the feeding therapist if unable to advance the feedings. The next one is optimizing the oral feeding. Monitoring the infant weight, trend, and on oral feeding. Continue to monitor for physiological behavioral stability with oral feeding. And confirm parental caregivers availability to support them to experience the feeding skills for the baby. So the takeaway point is here, respect where each baby is neurodevelopmentally. So when the baby is born premature, they'll be having immature sensory systems, immature physiological system and all. But we have to respect that, recognize and interrupt their behavior cues during feeding, respond to the behavior cues during feeding by offering appropriate pre-feeding and feeding strategies. Our goal is to ensure that every feeding experience should be positive. For being positive, we have to really understand the fetal development reflexes. We should understand the cues, how to interrupt the cues, how to communicate, how to correlate the baby. These are very essential and pleasant and nurturing time regardless of the size of the age of the infant. So there are a lot many courses if you wanted to, there are forward courses like if you want to improve yourself more in ICU, there's something called Ignite Core Mentorship Program, and then newborn NWAS and NBO fine, and there's something called Sophie Method. You can check on NAND, NAN, these are the websites, you can just find the resources, and then infant-driven feeding, all these things. Feeding Matters is one of the other wonderful website. You will get lots and lots of free resources which will help us to go for this learning about NICU, and all these things. Other three are it's a paid courses where you can improvise yourself more in the field of NICU. Any questions? If you have any questions or any further things or you want to ask anything, you can always contact me, and this is my number, it's my email ID.
Thank you so much, ma'am, for a wonderful presentation. There is a question for you here. If the infant is on NG tube or ND tube, what precautions to be taken when giving chest physiotherapy?
So I think Dr. Sujata told about this thing. When the baby is in NG tube and all this tube, we have to be very careful. We have to protect the baby. So we have to respect the cues. We should protect them by giving the positive experiences by I don't know, chest physio. I'm an occupational therapist. I will not recommend chest physio. That will be harming. But for their suctioning or some other reason, they will be using chest physio. But chest physio, a lot of studies are telling it is a contraindication. There are a lot of positioning is there for that. But so yes, here we have to protect the baby. When the baby is there, we have to protect. When the baby is in NGO and all this thing, all we have to do is protection. We are not going to do any stimulation. We are not going to do anything unless and until the baby is medically stable, medically, physiologically, all they're stable, and as for the gestational age.
Dear participants, kindly unmute yourself and ask questions also if you haven't typed. I missed your one of the questions, so kindly unmute yourself and ask the question.
Okay, there is a question on the chat box. Please write the website you have mentioned where we go through the research papers.
Okay.
So Geeta, can you just type in
Yes,
when you're free so that people could know about those websites like
Sure.
the NANT and the NAN, whatever you said. Probably
Yeah.
if you can give the links to the
Sure, I will.
website. Yeah, thank you.
Shall I do immediately? Can I do later also?
Yeah, you can ask people.
Any other question you're having?
Yeah, ma'am, this is Mithila. I'm a practicing neurophysiotherapist.
Okay.
Ma'am, I have a question that what are the absolute indications for chest physiotherapy in NICU infants?
As I told you, like, because I'm an occupational therapist and chest physiotherapy, I may contraindicate like for this thing, but chest physiotherapy, many studies
Is Sujata there around? Probably she can take the question.
Yeah. Chest physiotherapy is a little bit harmful for the baby because you can do the positioning for it. There are a lot of researchers are saying, I can share the links also to you about the same regarding this.
There is a question from Kartika Dharani that children with seizures disorder, epilepsy, generally have difficulty in number one, accepting different textures of food, even liquids.
Yes.
Second one, swallowing time are delayed. Do you have any suggestions in terms?
Can you please repeat second question? First, they will be
swallowing time are delayed.
Okay. Sorry. Repeat it.
Like kind of swallowing time.
Okay, swallowing.
Yeah, is delayed.
Yes. When the children who are in ICU, as I told you, they will be having a lot of tubes in their mouth. There will be a lot of suctioning happens, and they had a very bad sensory experience. And these children, they will be having difficulty in many of the times. They have a lot of oral control is not there. The first main thing is like they had a very bad tactile input, very bad experience at tactile input. So whatsoever they put, the brain will just trigger, and they remember the bad experience which happened in the NICU when you're a young baby. So that is also reason they have the aversion. So when it's coming to the epilepsy, they may have undergo a lot of medications, and also that is also lead to the poor intake of food. And the aversion is, again, we have to see whether it is oral control, whether it is a sensory problem, whether it is a psychological problem, what are the history the baby undergone when they were young. So we have to really consider these things. And many of the times we have to go further. The child is having issues in sucking, issues in tolerating the food in the mouth, where the child is having problem in chewing, where the child is having problem in when they grow up. If you're talking about the little bit grow up, you have to see how much is their tongue control, how they are taking the food to the teeth, and how the bolus is going inside. That also matters. So when they are in ICU, the 90% of the children, they had a very bad experiences, very bad sensory experiences. So that have the major impact when they grow up. They'll have a very poor feeding skills, and many of the times they will have a lot of sensory processing difficulties.
Have anybody any question? Okay, ma'am. Thank you so much for your wonderful presentation.
Thank you for the opportunity. Thank you so much for listening. Thank you.
Thank you so much.
Excuse me, Saurav, sir.
Yeah, please, Mithila, go ahead.
Yeah, sir, you mentioned in the Q&A section right now that a previous ma'am can answer the question because, sir, because doing chest physiotherapy in NICU is a traditional practice. I mean, I don't know what are the absolute indications and contraindications for doing, not necessarily the tapping and cupping, but what are the absolute indications for chest physiotherapy in NICU?
Hi, Priya, right?
Mithila.
Oh, hi.
Yes.
See, I understand traditionally we all used to do chest PT and positioning as PKs. I guess that's what we used to do in the NICU.
Yes.
But personally now, with the experience and what we see, and looking at all the cues that the child is showing and the sensory development, I would say that look at how you can position the baby, which helps in drainage, rather than doing going and doing a percussion or a vibration.
True.
You can help a lot through positioning. If the suctioning has to be done, we have a practice in the NICU before feeding, they do a suctioning, which I feel is not good personally. but then that's the nursing care procedure and they follow it, then I
Yeah.
would suggest that look at containment. Give the child the contained tucked position if you're going to be doing the suctioning at that point of time.
Yeah.
Yeah.
Okay.
I hope
Yeah.
I
Okay.
addressed that question. Thank you.
Yeah, because the first step that we do is after observing a child, we go for auscultation. And if we find any secretions in particular lobe, we position a child in specific angle so that the secretions come centrally, and then do with the suction. So, as in, no, I'm not referring to exactly tapping and cupping, but sometimes the suctioning is essential for their ventilation. As in, so is it
Yes.
absolute? Yeah.
Yeah,
So.
I understand, and it is necessary. Yes, suctioning is necessary in certain cases, and we
Yeah.
have to do it. But at that point of time, if we can give this child a contained position when the child is at least comfortable, use the breast milk at that point of time so that the stress is reduced on the child. So look at
Right.
these parameters where you can help the child relax when you're doing all these procedures. I would
Okay.
prefer that the suctioning does not happen immediately before a feeding, because when you do
Right.
the suctioning and then you go for feeding, it becomes a negative experience for the feeding.
Yes. Right, ma'am. Yeah.
Okay.
Okay. Thank you, ma'am.
Saurav, there is another question to Geeta.
Yes, I could see that. Yeah.
Yeah.
How long present in NICU leads to sensory issue?
Sorry, how long?
Present in NICU leads to sensory issue.
See, it depends on it depends on how bad was the sensory experience the baby have undergone in their NICU, how bad the baby was being handled, how bad the severity, what's the severity, how the baby was handled. So it depends on that, and how the baby have been given a protective environment, whether baby when they have undergone the negative experience, whether the caretakers or the parents are given the positive experience for the baby or the baby have not provided. So it depends on how much the baby
Get up.
experience, how much the immature
Get up.
baby experience the
Get up. Get up.
experience the sensory input, negative input. It depends on that. Hope you're okay with the answer.
Okay. Okay. Thank you so much, ma'am.
Sorry to interrupt, sir. This is Varsha Venkatraman here. My question is to Dr. Sujata ma'am, if she is on board, regarding the previous question regarding chest PT. Can I proceed? Is she on board?
Yeah.
Yeah. Sujata ma'am, my question is, when you mentioned that when we are going to do stressful, like when there is case of pneumonia or something where suctioning is unavoidable, we have to do it to improve the child's ventilation. So you mentioned about giving them contained positions. So if you can just give more examples on how we can provide them support when we are going to stress them with these procedures.
So yes, so when we are suctioning the child, instead of keeping the child flat on the back when you're doing the suctioning, because that's what normally the nursing care do,
Yeah.
flat on the back, you could probably just take them to a little lateral position, get their hands towards the midline, give them a thumb or a finger to hold on, because that helps them regulate. You can also give them a little flexed position, like I had shown in my slide, the nesting position. You
Yes.
can look at doing something like that. Or you can look at swaddling them, because those things support the child to regulate. So when there is a negative input, like a suctioning is a negative sensory input, so at least when you have the other factors contributing in the protective system, the negative impact is less. I'm not saying there will be no negative impact, but at least you're looking at reducing the negative impact of the experience.
Okay, ma'am. Ma'am, and one more thing, when we when we give them positioning with an intention of improving their air entry with respect to their ventilation. So that time, how I mean, I have when we have worked in my college, that time I've heard my staff saying that okay, not more than 5 minutes in any position or something like that. Is there any restrictions that way when giving positioning for chest ventilation? I mean, when we are giving position with the purpose of improving ventilation, is there any timing conditions or something like that?
No, it all depends on the behavioral cue that the child shows you. Like we know that positioning in prone is supposed to improve the airway. So you can give that, but you have to look at the behavior cues that the child is showing. Look at the physiological parameters. If you feel that the physiological parameters are stable, the child is able to tolerate the position, I see no harm in that.
Okay, ma'am. Thank you, ma'am.
Thank you.
Thank you so much. Thank you so much, ma'am, and dear participants who asked the question. Next presentation is by Dr. Manish Samnani. Sir is already on the video. Can welcome you, sir.
Thank you.
Banner.
Thank you, everyone, and good morning. Am I audible?
Yes, yes, very much, sir. So he's going to present on the does sensory processing influence early motor development? How do we intervene early? He has a long credentials. He is on advisory board to InSync Hyderabad AC School Gurgaon, Luis Kolkata, Autism Center Ludhiana, Sehat Chittagong, and PET Bangladesh. He has certification in sensory integration and certification in NDT and trained in developmental assessment skills for Indian infants. He has served in PDDO IPH, IIS, ISIC, Jamia Hamdard University, and contributed as academic faculty for graduate and postgraduate OT students. He has presented paper in conferences of AIOTA and European SI Congress. He has developed and presented parents and professional workshops about OT in autism, behavior, and sensory integration in multiple cities across India and abroad. He is a PhD scholar. Welcome you, sir. We are very thankful to you have on board. Yeah,
Thank you.
thank
you so much. Thank you so much for inviting me, and welcome everyone, all the designated faculty members and all the participants. And as you are aware, I'm sure you all must be feeling a little bombarded since morning. You have lot of lectures lined up today, and I'm also sure that all of them must have also told you that a topic like this or their own topics, it may not be a very good or enough time to present it into this many minutes, and so same is with me, that the sensory is quite a wide and a broad topic, but let's hope that we would be able to do something, develop some insights about it. So in the today's topic, we are primarily focusing on how sensory processing may have an influence on the early motor development, and secondly about how can we intervene about it. So Jean Ayers in 1950s started to think about something. She thought that maybe it is not just the motor dysfunction that leads to, or the treatment of the motor dysfunction alone does not help the child with cerebral palsy or other neuromotor dysfunction. So as you can see, it is very interesting to see that the hypothesis of sensory processing, sensory integration had actually started from children with motor dysfunction. Although as far as literature or research is concerned, Ayers then went into developing the theory more on learning disability population. However, it is quite interesting to know that her initial hypothesis in 1950s, which is more communicated through her personal communications at that time, was more primarily after looking at children with neuromotor dysfunction or children with motor difficulties. Having said that, Ayers is said to be ahead of her time. She was ahead of her time because at that time, nobody thought that there is something else that is contributing to the functional difficulties of children who have primarily a motor disorder. Whereas she then later on in 1980s, along with others in 2009, as you can see, have actually summarized that in fact, it is the sensory processing deficits in children which can have a difficulty, which can have an impact on developing accurate motor programs within the brain. And so the child does not have a good representation of the actions that he's trying to perform. Meaning thereby that even if a child gains the muscle strength, he gains the musculoskeletal abilities, or the impairments are not there, even then the child may not be able to return to function. That's what sensory processing kind of a difficulty can have an impact on. So Ayers ultimately developed a bigger, larger theory where she said that in fact the vestibular, tactile, and proprioceptive system working at level 1 are the core sensory systems over which the other higher abilities like vision, auditory, learning abilities are also based on. So it's in fact the integration of the proximal senses, vestibular, tactile, and proprioceptive, that ultimately led to development of further abilities. The vision here does not mean sight. The vision here basically means the visual processing. Now, if we look at what kind of abilities or what kind of constructs the sensory processing relate to, or what kind of construct the sensory processing develop into when we treat or work with sensory processing kind of a frame of reference, you would see that although sensory is regarded as the roots of a tree, as you can see in the slide, where all the sensory systems are like the roots. And when we say roots of a tree, we mean that these are the sensory systems or these are the processes.
Dr. Manish,
that, yes,
just a minute. Are you sharing your screen?
I was.
Can you just go? Yeah, I
Gone.
think it's gone. Yeah.
Okay, okay.
Can you please
Was it, it was there initially?
It was
Yes.
there initially, yes.
Okay, okay, okay. Okay, let me do it again. Is the slide visible now?
Yeah,
Yes.
perfect.
Okay, great. So it's just the next slide. This was the first one, and the next slide, I'll continue that the sensory systems are regarded as a roots of a tree which you can't see. But what you can see is that based on the sensory inputs, based on the integration of the sensory inputs, you ultimately develop certain constructs which are more relevant to sensory integration, which are like body awareness, postural stability, bilateral integration, midline crossing, which are in a way part of the gross motor functioning, and the other abilities or constructs developed through ocular motor control, where the visual and the vestibular system integrate together, the manual dexterity, and we will talk about it, how it is a role of the sensory, the precision, the visual motor integration, which are primarily concerned with the fine motor abilities. So in that way, you can see that the sensory integration, although talks about integration primarily of the tactile, perceptive, vestibular, and visual inputs, there's a huge connection that is there between the gross motor and the fine motor abilities that we typically intend to develop ultimately as an improvement in the sensory abilities. Let's talk about the tactile system. Now, the tactile system, as you know, is the receptors are all over the skin. But what is more relevant for the tactile system as far as sensory integration is concerned is that we all know that a reflex like rooting is dependent on the tactile stimulus given to the child's face, and hence the child has a response to it. Similarly, a piece of a cloth placed on child's face ultimately leads to a reaction from the child where the child would like to take it off. Now, you might have an opinion or you might argue that these responses are reflexes in fact. However, the sensory integration theory says that although these are automatic, although these reactions are definitely automatic and reflex oriented, however, if your tactile or proprioceptive sensory systems do not integrate well for any reason, which includes a neuromotor dysfunction, then these reflexes would not be expressed in a meaningful way, which means you might have an over response or an under response to touch and the child may or may not be root to the meal or to the nipple that was the primary function of that reaction or reflex. He might be unable to do it even if the reaction is present. Now, these sensations, tactile and proprioceptive sensations taken together in a child that leads to a motor response that we just talked about are in fact called as somatosensation. And the responses or the physical responses that we talked about, like the child moving the head in the direction of the touch as a rooting response, or the child taking off the cloth from the face, is actually involving an amount of motor planning from the child, which would, in the sensory language, is termed as the somatopraxis. As you can see in the diagram as well, that how the somatosensation is actually nothing but the integration of pain, temperature, touch, vibration, body position sense, and ultimately leads to what and where of the sensory information. Which means that even if you have a physical strength to carry out the reaction, your what and where goes wrong if the sensory inputs are not getting integrated. That's the link between the tactile and the motor development that we talk about. Another simple aspect of the connection between tactile and motor is that by 2 years of age, usually children would have an ability, what we call as the localization of touch, where you could understand localization touch as ability to pinpoint or perceive touch exactly where it was given to the child's body. Now, tactile localization is important not just because the child should be able to point out to the touched surface or to the exact point for by precision. The tactile localization actually leads to development of what we call as the body perception. The word body perception basically means that your body responds to your physical situations, or your body responds through a physical or motor actions, not just by vision. If you see in the picture given, the child's eyes are not in the direction of the movement. The child is actually responding to the tactile localization that the other sibling is giving to this child, to the ear, maybe to the cheek or to wherever. But as you can see in the motor response that the child is giving, he's actually using the somatosensation driven by the tactile and proprioception and not by vision. These abilities, or your ability to localize touch or respond to touch, are also categorized under a broader category called as the sensory discrimination. When a child would have difficulties with tactile or somatosensation, wherein we take in the tactile and proprioceptive sensation taken together, you will have a child who might have good ability gross motor wise, but will have difficulties in tasks of dexterity, in hand manipulation, or you could say fine motor skills, or the child will actually have difficulties, as we just said, in precise touch information from his hands. So thereby the child will have difficulties in terms of fine motor abilities much more. Now, having talked about tactile in very short, and this could be the concise way of looking about it, talking about it, although there are many more details to it. Let's see how we can intervene about it. Now, if I want to work with this SI frame of reference, the first thing in my mind is to give an experiential learning. Remember that SI does not believe in practice, in repetition of movements. It is not dependent on the motor control theories and neither on the motor learning theories. It's more dependent on having an experience of the touch and responding to the touch. And that will ultimately lead to an adaptive response from the child. Let's talk about that. Now, if I had to assess a tactile localization, whether it is present in a child or not, I might use a very simple test, which you all know is point to where I touched. You will touch the child at a specific point on the palm or forearm or elbow, and you will tell the child, where did I touch you? And you will actually measure the distance between where the child was actually touched and where the child actually pointed to. That's one of the tests as a part of the sensory integration and praxis test. However, you might again opine or argue, what about children who cannot respond, or what about children who are too young to understand this kind of a test? Now, sensory integration has developed a way of doing assessments which we call as the clinical observations of SI. So let me give you an example for tactile localization. Like you see the child in a ball pool. If I were to test tactile localization, I might just pick up a ball and playfully slip it into the child's shirt somewhere in his back. Now, if the child turns towards his back, tries to reach out his hand towards the source of touch, which is the ball touching his skin between his shirt and the bare skin, if he reaches out to it, I might say that the child does perceive touch and does show a tactile localization response, whether or not the child is actually successful at taking out that ball from the shirt. Whereas if a child has no response to it, I might say that the child did not register And sensory registration is a big cluster of difficulties that we do test in children with or without neuromotor dysfunction. Now, what do we do for intervention? And like I said, in the interest of the time, I have again taken up tactile assessment in the briefest or in the most concise way that was possible, because tactile has lot many other constructs. But just for the sake of our academic brainstorming, I have taken it in a concise way. Now, if I were to do some kind of an intervention with early motor, with the purpose of early motor development, I might use activities where the child will be actively engaged, where the child will be participating. Remember that the sensory integration provides opportunities for sensory stimulus, which you could see that there are sensory stimulus available. The opportunities available should be such that the child should be feeling invited by the sensory stimulus. The child should feel that the environment is actually promoting his responses, and the child is not really instructed for it. The child is not really physically given assistance for it, but is rather looked after as giving or eliciting a response. In this case, if this response is elicited and not taught, then it would be called as an adaptive response. Let's see more examples. A child playing with cold water or ice cubes could be another example. And you can see, as in the picture, you could see the level of engagement of the child, the level of organization in his behavior about actively exploring the tactile stimulus of the cold water or ice cubes. That itself is the adaptive response here. Few other examples of tactile stimulus, and I have deliberately taken stimulus that are easily available and not really looking for, because I know sensory integration is a lot of time criticized for being dependent on a lot of fancy stimulus, a lot of fancy equipment. So I'm trying to take up some certain stimulus which would make our understanding a little easier, simpler, and also will give us an option to practice them easily. So if you could use any kind of tactile stimulus, this on one side you see pasta, on one side you see the beans or any kind of vegetables that the child can play with. But important thing again in sensory would, and I'll keep repeating this, is the active engagement, is the participation, is the adaptive response elicited and not taught to the child. Similarly, you have other options of giving tactile stimulation, although the word stimulation is not a very good word as far as SIFOR is concerned. Typically, the word is sensory experience. And so you could see in one of the pictures is the spaghetti, the noodles, mixed with lot of aromatic coffee crumbs mixed with it, and the child engaging in it, maybe with another sibling as a peer interaction. But it's more for touch and aroma to give the multi-sensory input. The other example that you see is about playing with rice. And if you see even with the still pictures, you can say that there's a lot of adaptive response here, and it's not a response that is being taught to the child or the child is made to practice it again and again. A lot of times in the messy play, we can use even the sources of food, a paste of wheat, a paste of maida, or paste of besan can be used. You can use sprouts as a source of food or source of tactile. Give the child to explore it, give the child to discriminate, if maybe hide something inside and try to and see if the child can actually point out to it or take it out from the whole thing. If children are a little older, you could safely use with them some other media which otherwise are not very safe for mouthing. Remember that with the early motor development, you in the previous examples, all of them examples, most of them are pretty safe for mouthing. So just in case your child is mouthing, you can still use it. However, in this one, they're assuming that when children grow up, we might actually be doing some other media like sand or clay or a few other things. Remember that tactile or sensory stimulation or sensory experiences are not just by hands, are not just by touching it. When you play with it actively, it involves using your feet as well or using your body as well. You could actually lie down in it, like the child might lie down in a ball pool. So the ball pool might act as a source of tactile stimulus. Like I was talking about tactile discrimination, and you could have an activity where the child has a bag filled with chana rajma rice, whatever you would like to do, and mixed up with some toys, and the child is supposed to take out that particular toy or object of his choice, or as told to him by the find out, can you give me a car, can you give me a eraser. Now in this case, the adaptive response clearly is not just motor, it's not just sensory. The adaptive response in this case would be cognitive as well, which is usually a good choice or a good way of doing sensory integration depending on the child's age. Let's come to the next sensory system, the proprioceptive system. As you know, the proprioceptors are basically in the muscles, in the tendons, and the proprioceptive system also has a connection to the motor development. An example of how the proprioceptive system and motor are connected at a very young age is that an average 1 month old child would usually adjust his body to fit nicely into the arms of the person holding him. Now, this response is not by his vision, is by his muscles and joints that tell him what shape to take by his own body, so that he gets snugly fitted into the space that is provided to him by his parent. Again, this is an adaptive response, and it is an adaptive response because nobody instructs the child, teaches the child to do it. He responds in this way by way of his receptors actually responding to the sensation. Now, the same sensation that he was showing by adjusting to the arm of the space of the caregiver is later on used in much more broader way, using your knife and fork, using how to climb a jungle gym. Proprioceptive in itself basically mediates force gradation. How much force should I apply on an object? The force applied on a sharpener and an eraser is different than the force applied on a hammer. And the joint position sense, like you could see in the picture, if a child has proprioceptive difficulties, the joint position sense usually gets affected, and the child might do passive locking of the joints. I'm assuming in this picture that this child may not have a neuromotor dysfunction, or the neuromotor dysfunction has been assessed and has been improved to such a substantial level that even then we did not expect him to have these joints, but he does have it, probably because the proprioceptive system still hasn't kicked in as much as the motor system. So along with the tactile system, like we talked about, the somatosensation, the force of the grip, the fine motor abilities, the coordination are all the functions of the proprioceptive and tactile. Now, an important ability that a child develops in terms of his motor abilities when it comes to proprioception is what is called as the praxis. Praxis or motor planning, or also called as somatopraxis, is the motor planning abilities that the child would have as an integration of the tactile and proprioceptive both functions. So this is not an individual function of the proprioception, although, however, it is very, very important to discuss it. Now, how would we know in a child who has a neuromotor dysfunction, say, for example, to say whether the child also has a sensory-based motor planning disorder? And I have deliberately put this example here, is that when a child knows how to get onto an equipment, suppose he knows how to get onto a swing, but while getting down, he does not know how to do it. He just doesn't figure out what is the sequence of action here. What should I do first to make sure that I am getting down from the swing? Is a classical example of motor planning difficulties in a child with neuromotor dysfunction, where he does not have a clear plan to do it. His motor abilities might be good enough because that is how he was actually able to get onto that equipment on his own. Sensations from the body provide the necessary information for these planning of movements. And these sensations from the body are typically proprioceptive and tactile. As young as 8-month-old child do have these motor planning abilities when they are showing you activities good enough to do ringing, pressing a bell, putting things together. Maybe, the stacking ring activity that we typically do with a lot of children can have these abilities. If the child has at 8 months, he's actually clearly showing you that he has good motor planning abilities. Now, a child who has quite high neuromotor dysfunction, but he's able to verbally tell you how he can get onto a swing, but he actually cannot do it physically, would be regarded as a child who does not have motor planning difficulties. I just put it to make sure that we have some understanding on how we differentiate difficult children with motor planning difficulties, because a lot of times we might think that the child with severe motor dysfunction has no chance to have, will always have a motor planning deficit, which may not be true. Now, how do we work with these motor planning difficulties? The current theories support that the movement and sensation are related together, and hence when we do the intervention, we also take them together. The physical activities and the sensory needs to be taken together. An important guideline to work for children with tactile proprioceptive difficulties is to include feedback related activities much more than feed forward related activities where a lot of movement is required. So the feedback related activities are more required for developing somatosensation. And in another guideline to improve proprioceptive input to the muscles and the joints is to use a lot of resistance. And I'll talk about some examples. Now, in the activity shown here, both of them, you could see that there is a lot of element of tactile touch, that the child needs to hold it, grasp it, apply some force. There's a lot of resistive activity being done in both of them. These kind of activities, and these activities are feedback based activities. They do not have a component of feed forward. They do not have a component of moving in the space, anticipation, timing. They do not have that component. So remember that if you are doing a feed forward related activity, you may not have a very good input to the tactile proprioceptive. You might have actually input going towards the proprioceptive vestibular kind of abilities. Both these activities are a good example of including feedback and resistive activities. If a child is little more capable, you could actually involve, and if he has minimal neuromotor dysfunction, but you still feel that the somatopraxis is still to be worked on, you could actually work with give him activities that are typically regarded as a fine motor activity. But remember the concept of feedback and resistance. As you can see in an example, there is a tennis ball that is cut, and it is just an example. You can think of various activities around it. The tennis ball is cut. It has become a mouth of a favorite character. Now the child has to press with the left hand, apply some force, feel the texture of the ball, apply enough force that the mouth is open and is not continues to be closed, and then do an activity of feeding the tennis ball, which will be a very good example of a feedback related and resistive activity for increasing somatosensory input to the child's hands. If we are talking about sensory, we always talk about a just right challenge, which means that when children are even more capable, or if you have children who do not have neuromotor dysfunction as an history, as a neurological history, but you still see a lot of difficulties with their motor planning, you will need to give them activities of physical activities, of course, but remember, you'll have to work on the somatosensation and you'll have to challenge them enough, which means that I'm just including an example here. The child has to press the plate hard enough so that it doesn't skid out of his feet. He has to feel the plate all the time. He cannot use his vision, which means he would be using his proprioceptive abilities, and he has to do an activity of either racing with another child, maybe start and end of the activity. Another activity that you see, the dino feet, another simple example, the child is given a satin ribbon. There's a big cardboard feet given to him. And this is a wonderful activity for praxis because this is a new motor challenge for the child. Remember that praxis will always be elicited when the motor challenge is new for the child. And since the child hasn't walked before ever, he has walked before with chappals or sandals or shoes, but he hasn't walked with elongated or large size artificial feet, he would have to really think about it. He'll have to plan how is he going to manage the feet which is tied to his feet, and he has to also constantly feel the feet. If you instruct the child not to look at the feet, rather look at some other target to reach to, you would actually be working on proprioception as well. a sensory jungle. As you can see, there are certain obstacles, and the children are supposed to not break the paper ribbons. They have to manage their bodies using their proprioceptive abilities in such a way that they don't break it. They have to be absolutely sure of what the position of the ribbon is and what the position of the body is in relation to each other, so as to successfully do this task. And hence, this activity again should be regarded as a praxis ability and also a tactile proprioceptive activity. Let's come to the third sensory system, which is the vestibular sensory system. Now, the vestibular sensory system also has a link to the motor development. Now, as far as vestibular system is concerned, developmentally, the vestibular system has three major connections. One that supplies to the inner ears and senses the sense of gravity. Second is the sensation that is going to the eye muscles or ocular muscles. And the third that goes to the muscles of the neck. The brain puts all these three sensations together and is responsible to hold the eyes and neck steady. As you can see in the picture, when a child swings, when a child is moving in the space, his head position is being maintained, his eyes positions is being maintained in a good and an adaptive way because of the postural ocular responses that the vestibular system is responsible for. Now, these responses, postural ocular responses, are not just responsible for maintaining a good position of the head, neck, and eyes. They are ultimately responsible for the ability to learn, read, and balance overall body. So this is what Ayers had hypothesized long back, that the vestibular or proprioceptive or tactile sensory system as the basis of all other higher abilities like reading and writing and learning was this connection, where she said that if a child is not able to focus on a whiteboard or a blackboard, if a child is not able to read very well, it might be that the postural ocular responses are affected and because of the underlying vestibular system dysfunction, and hence are leading to the learning or the educational difficulties, and not because of the behavioral difficulties. There's a whole lot of science that Jean Ayers then developed during her PhD and afterwards. And ultimately, sensory integration got a recognition to be a very good approach to be used with the dyslexia or learning disability population in due course of time. And the first generation students of Ayers developed it further to include developmental delays, cerebral palsy, autism, Down syndrome, and any other developmental difficulties are now being treated by sensory integration. In India, traditionally, we are using sensory integration with a lot more severe and moderate dysfunction, which we typically see under the autism spectrum, ADHD kind of a dysfunction as well. Now, how does it connect to the early motor development, our vestibular system? Newborns show responses to the sensation of gravity and movement. How do we know that? As young as 1 month-old child can be seen to try and raise his head up when a regular, we are talking about a regular normal child, when a parent, as you can see in the picture, when a parent is holding a child on the shoulder, the child would actually intermittently try to lift his head up on his own. Now, this happens not because the child has a voluntary motor control of the head and neck. It happens because primarily the pull of the gravity stimulates the part of the brain, or you could say stimulates the receptors in the inner ear, and thereby stimulates the part of the brain that have integration of the vestibular input at the brainstem level, that ultimately stimulate the neck muscles, as we talked about, that the vestibular has a connection to the neck muscles. And these neck muscles then help the child, or even you could say these neck muscles actually give an urge to the child to raise the head up. Again, this is an example of an adaptive response, because this child was neither instructed to do it, nor he was taught to do it. It's an urge. It's an internal urge to do it. Internal locus of control, sometimes we call it. And that's what we are trying to develop when we are trying to use the sensory integration frame of reference We are deliberately not using repetitive activities. We are not using a lot of instruction. We're trying to stimulate this very vestibular system that will ultimately have a positive influence on all the three other connections that we talked about, and ultimately help us in the in the child who has a neuromotor dysfunction, as well as for children who do not have a neuromotor dysfunction but have primarily a sensory integrative dysfunction. The same neural mechanism holds an adult's head upright without deliberate effort. And I have put this because I thought that, again, many of us might feel that the head raising in an adult is a voluntary activity, is a voluntary motor control example. However, remember that in an adult, both the mechanisms will coexist. So when you are actively holding the head up, because you have decided to do it as a cognitive task, because you are responding to an environmental stimuli as a cognitive task, you are of course using your neuromusculoskeletal system to respond to the neck muscles. However, remember that all of us are maintaining our head upright even without a real need for making it upright from the environment. It's our internal urge to keep it upright and in the midline. This is what sensory is talking about more, that we keep our head upright without a deliberate or with effort to do it. That's what the vestibular system's role in our body is. Having said that, you could easily say that the vestibular system will be having a role in all activities that a child does, whether it is reading, whether it is writing, whether it is a voluntary motor control kind of an activity, the vestibular system will have a role in all of them. Now, as after 1 month of a child, another good connection between the vestibular and motor response is seen at 6 months of age. Prone extension, as you might all know, is a response that you would see as a reflex or a reaction to lying down on prone. However, the vestibular system is again the contributing factor here. In fact, this is how the early development of core muscles, the early tonicity of the core muscles develop as a response to the vestibular sensation that you get in your neck muscles or your postural ocular muscles when you are lying in a prone position. Now, older children who cannot hold this position often have problems integrating gravity and movement sensation. This is what we conclude in children who do not have neuromotor dysfunction, but when they are tested on it and they are not able to do it, you could easily say that probably they have some difficulties with their vestibular processing. Now, prone extension is also, as you know, are a vital step in developing other motor milestones like rolling over, standing up, and walking, which is again the connection, secondary connection between the motor development and the vestibular system. Similar to this age, one of the other constructs or abilities that develops as a part of the vestibular system is called as the bilateral motor coordination. This is your left and right brain coordinating together. This is your left side, right side coordinating together. And if the infants at 4 to 6 months of age do not show or do not touch their hands together, if they do not bang their toys together, you might be looking at children who have a difficulty with bilateral motor coordination. Remember that, of course, you will have to do a little more clinical reasoning to find out whether this is primarily happening because of neuromotor dysfunction per se, or this is happening because the child has primarily a sensory integrative dysfunction, or this is a sensory integrative dysfunction. However, it is coming out of the primary neuromotor dysfunction. You'll have to use a little bit of clinical reasoning skills and your current neuromotor profile of the child to be able to discriminate that. Let's look at the intervention for vestibular. Now, when it comes to vestibular, remember that what are the underlying mechanisms that we are talking about? We have talked about 3 mechanisms in vestibular. We talked about bilateral motor coordination. We have talked about prone extension as relevant constructs of vestibular system, and hence the activities would be designed according to that. Now, I have included few activities to show you which can also be given to children who might have difficulties in the typical sensory equipment that we say, okay, if my child has a neuromotor dysfunction, how could he ever balance on the vestibular apparatus or vestibular equipment? swinging and spinning and moving is difficult for children because they have primarily a neuromotor dysfunction already, putting them into a disadvantage. Let me show you some examples. Motor planning, as far as vestibular system is concerned, as a construct, is feed-forward mechanism more. A feed-forward mechanism motor have contribution of the vestibular and proprioceptive systems both taken together. So remember that whenever we are working with motor planning as far or vestibular systems, we may not be working on it isolately. We might be working on it along with the vestibular proprioceptive. However, the nature of activities will change drastically. And the nature of activities will change from feedback related activities to feed forward related activities. And here are some examples. Now, if you see the typical feed forward related activities require the child to be moving around in the space. They also require a sense of timing, anticipation. They require motor planning for sure, but this is a different motor planning than somatopraxis that we talked about. The ball activities are very good examples of it. And some of these activities, as you can see, the first picture, as you can see, the swing is actually supporting the child's body to a larger extent than only supporting only the tummy area. And that is deliberately for children who would have a primary neuromotor dysfunction, because when we are working on the feed-forward related vestibular proprioceptive kind of a mechanism, we do not want this neuromotor disadvantages to take over adaptive responses that he would otherwise be able to give. Similar good example is a scooter board. Again, you could have a scooter board which is big enough, broad enough, and long enough to support the child's body. A scooter board is a very good example of eliciting prone extension. All of these examples are good prone extension. Now, if a child has difficulty holding or gripping, as we typically see in children with neuromotor dysfunction, we might actually ask the child to move the body itself towards the object rather than the ball or the object being held in the hand. So in order to take care of the neuromotor hand gripping disadvantage, if you see the last picture, the child is not supposed to knock down the cups with the ball or the stick in the hand. The child, he or she is actually supposed to move himself completely and knock down the cups. So in that way, you are not really giving him disadvantage of gripping an object. So sensory can give you opportunities to move the whole object, move you as a unit rather than move an object that we typically see. These are another good examples of eliciting prone extension as a valid vestibular construct. You could see that if a child is young, you don't even need an equipment to elicit a response. The caregiver, the therapist can actually hold the child in such a way that the child actually elicits a prone extension response. You could use various kinds of swings, single suspension to give you a lot of angular movement. You could, instead of using a hard surface like we saw in the previous example, you could use a soft surface, you could use a lycra, you could use a net kind of a material, which would actually not just support the child's body, but would also allow the child's contours, body contours, to be so placed that the child will have minimal effect from the primary neuromotor dysfunction. You can also see another picture where the child is being given a lot of adaptive positioning equipment while being on a swing in the last picture. So here, these are examples of how we should be able to combine the NDT and the SI frames of references. And in the end, remember that the behavioral characteristics that we sometimes see in sensory, I have deliberately not talked about them, where we talk about the child being very sensitive to touch, the child being very sensitive to movement. All of them are very much valid constructs. In the wake of the time, I agree that there will be a lot of behavioral things that you would have to keep in mind, but since they do not have any connection to the motor part of it, I did not include them. Children, when you touch them on their bare skin, you might see very abnormal responses, emotional abnormal responses of crying, getting upset, irritated. If you are touching them with the way we touch in NDT, you have to just keep that in your mind. You have to just keep that your hand is not just a facilitator of the motor action. Your hand is also a source of tactile stimulus to the child's body, which means that if a child is tactilely defensive, he might react negatively, and you will have to accommodate it. You don't have to you don't have to discontinue it. Probably you'll have to put a towel between your hand and the child's skin while giving facilitation of the NDT. You might also see responses of abnormally fear or apprehension when you take a child on the gym ball or to take a child on a bolster. And if you see an abnormal apprehensive responses, keep that in mind, that these are behavioral characteristics of sensory dysfunction. These are behavioral characteristics of sensory modulation, which we did not include today in this lecture deliberately, because they usually do not end up in a motor response. They rather end up in a behavioral responses. That's a whole lot of another topic altogether, but just giving you a primary idea that these things can happen during your session and you'll have to look out for them. And another rule of thumb to detect sensory processing difficulties while you are working with children having a motor dysfunction is that whenever you have an atypical response to intervention, meaning thereby that you could have an atypical response that we just talked about, abnormal behavioral response whenever you are doing a session of a child, abnormal behavior when you take a child onto an equipment or you touch the child, you'd see an abnormal response. Maybe the child is excessively laughing. It's not just always negative response of crying, but it could be crying, it could be laughing, it could be getting disoriented, it could be getting disorganized, it could be giving very emotional, upsetting responses whenever you give a sensory stimulus incorporated in your NDT equipment. Then you should be aware of it. And you should also be aware that if a child whom you earlier thought to have a neuromotor dysfunction somehow improves with minimal amount of NDT or minimal amount of motor intervention that you gave, so you thought this child will take a huge amount of time, or at least the expected amount of time that you had in your mind was 3 months to 6 months of a time or a year's time, actually improved within days. That would again be regarded as an atypical response to your intervention. When children are too fast in their improvement, you should start thinking, maybe my motor intervention was actually helping him to gain sensory input. And that's what the primary dysfunction was in this child. And hence the child improved much faster, much faster than he should have improved. If you see those kind of responses, you should know that you should think about the sensory. Thanks so much. And we are open for questions.
Thank you so much, sir, for your wonderful presentation. There is a question for you from Kanchan Wadwani. What can be done if the child who is having hemiparesis and can't supinate his hand? Child having hemiparesis can't supinate his hand. What can be done?
Now, if I would want this answer to be made relevant to the topic, and hence I will talk about the sensory frame of reference more than anything else, because otherwise this question can have a very broad answer, as you would agree. If I want to connect it to the current topic, I would want to assess whether this child has a good sensory or somatosensation in his hands. I would like to test that. I would also want him to get activities or receive activities which are relating to sensory exploration, sensory experiencing. Like we talked about, we gave you a lot of visual input on what kind of activities are we typically talking about when we want to give tactile input. So if I want to initiate a motor response, I would like to think that I would like to give him tactile and proprioceptive inputs to the child's hand in the form of a task, in a form of an activity, and not in a form of a, so I'm not talking about really rubbing on the child's hands, which you can also give if you see no response or no activity as far as the musculoskeletal neuromotor ability is concerned. If you do not see any kind of a response there, you might have to actually start with a lot of sensory based intervention, we call it. We do not call it sensory integration really, because sensory integration is typically always active. It is not passive. However, sensory based interventions are you could say not very pure sensory interventions as suggested by ears, but are very much relevant for children who have a neuromotor dysfunction. I would like to start with, depending on the child's neuromotor musculoskeletal profile, I would want to give him proprioceptive tactile inputs, either as a sensory based intervention or as an adaptive response.
Excuse me, sir, I have a question.
Thank you so much. Yeah,
go ahead.
Yeah. Please go ahead.
So if there was a child, like it's a preterm 26 week, and she has a visual problem, she can't focus. It's high cortical dysfunction only, visual deficit. So in that case, she is like already 2 years old, but still it's difficult for her to maintain her head position on trunk. She tries to do it, but not able to maintain it for more than 5 or 7 seconds. So as we know, there is a visual deficit. So what can we do more in that case, and then vestibular also along with that?
Yeah, you answered your own question. You did great by doing a clinical reasoning that the vestibular system is something that has a connection to the postural ocular system. Remember that the vestibular system has no connection to the eyesight, really. It has no connection to the vision. It has more connection with the postural muscles. It has connection with the neck muscles. So if I were to help this child, the sensory systems, also remember that they do not work at the peripheral sensory level. So even if the visual sensory system, as you said, as a peripheral system is not working, is not functional, I would still like to first assess the vestibular abilities of this child. I would like to give him some vestibular sensory experience, and see the typical responses that I would like to see whether they are there or not. I would also, along with as a team, I would ask my physio friend to see what the level of neuromotor dysfunction primarily is. Because if the neuromotor dysfunction is moderate to severe, we might see a child who may not be able to respond to the head and neck vestibular stimulation just because the neuromotor dysfunction is very severe. So it's a teamwork. Then I would like to really closely work with what kind of responses are still elicitable given the fact that there is a neuromotor dysfunction. However, if my physio friend tells me that the neuromotor dysfunction apparently is not that high, to the extent to which we are seeing the motor deficit here, or a motor function is too less than what the neuromotor difficulty is, I would like to be very aggressive in terms of my goals, in terms of my vestibular processing goals and efforts. So you answered yourself that we would like to give him a lot of vestibular stimulation.
Okay, thank you, sir. But in her case, there is neuromotor dysfunction also. There is a weakness also. There is hypertonia also. The child is actually dystonic. So overall, my thing is like, as we all seek the vestibular stimulation, like by doing the swimming things and all, can we add something else in that in terms of vestibular?
If I were to give you an example, if you remember from the slides, we shared certain uh, equipment which are a source of vestibular stimulation, which are like swings. Now remember that there are various kinds of swings available. You would have swing which have single suspension, and you will have a swing which has a double suspension. Now a single suspension swing always has more vestibular or angular input than a double suspension, of course, right? It's a simple physics that if it is double suspension, you're looking at more of a linear movement. Now, if a child has sensory difficulties, I would like to assess not just about the motor dysfunction being caused by the vestibular sensation. I would also be very aware of the vestibular modulation difficulties, which usually are expressed as behavior, like I talked about in the last slide. If I see a lot of behaviors or insecurity feelings, these are emotions that get expressed over from a child when the vestibular activities are given, I would first like to work on those activities. Reason thereby that if this child has vestibular modulation difficulties, his motor intervention as given by my team member might have a little lesser acceptance by the child. When I will work on my vestibular modulation difficulties, his work actually gets supplemented to be able to get more motor responses. That is why I said this would be a child who would need not just use of the two approaches, but would also use a very good teamwork between the physio and the OT. In terms of assessment, how much is the neuromotor dysfunction? How much is the functional difficulty relating to the motor dysfunction itself, and the OT or the sensory person telling you how much of the vestibular effect can or cannot be discriminated from the neuromotor effect, right? So now remember that the vestibular dysfunction in this child might be primarily caused by the neuromotor dysfunction itself, right?
Right,
So
sir.
you will never be able to differentiate between the neuromotor and vestibular. However, the expert in the sensory assessment would like to still do the assessment of the sensory function and would document his findings with keeping the facts of neuromotor in his mind. He would not say, he should not say that the head control is not there because of the vestibular system not kicking in. He should not say that, because he knows the neuromotor profile of the child as well. Keeping the neuromotor profile, he has to still emphasize on the pure sensory dysfunction that he looks at in this child. So this child, of course, requires a little more minute assessment of the sensory dysfunction, because the typical responses that you see in vestibular processing or planning will not be elicitable in this child, or rather cannot be attributed to the sensory system. So if this child does not show a prone extension, for example, one, this is not a child whom you are expecting to have a prone extension. Second, if you are expecting a prone extension, you are looking at a prone extension due to neuromotor difficulty, as in a neuromotor prone extension rather than a sensory prone extension. Are you getting, if you're getting my point? Here, the sensory dysfunction has to be assessed for very subtle sensory abilities. And so the documentation of those sensory abilities will become very important, because the goal of the sensory intervention will then be based on that. Because otherwise, you might overemphasize sensory systems as the contributor to the neuromotor, or you might completely lose on the sensory dysfunction as the contributing factor. Both extremes can happen here, which does happen in our clinical practice, right? Sometimes we don't even test sensory systems of these children, thinking that if the motor abilities are so poor, how can he even have a sensory, how can we even test the sensory dysfunction? But that's about the competency of the therapist. Actually, he will have to still figure out how to assess the sensory dysfunction here and make a relevant goal here. Yeah. So because the child is not in front of me, remember that I'm really hypothesizing here a lot. I'm really hypothesizing here. But what I can feel from your question, and not really going through the text, what I can feel here is the confusion between what's relating to the neuromotor dysfunction here and what's relating to the sensory dysfunction here, which is a very relevant confusion. That's the beginning. That's the start to have. And you would need somebody on board to tell you, okay, this part is not just about it's not just about sensory. Forget about it. Let's not even talk about it. Let's not talk about prone extension here, because we are not expecting that the child will have prone extension difficulties here, relate as contributed by the sensory.
Yes, sir. The sensory is dominant here, no doubt. In her case, sensory function is dominant here, but the challenge is to test.
Of course, like I said.
Sensory. Yes, sir.
Yeah. So I really wish we could do something. Maybe this platform may not be sufficient to kind of tell you, okay, this is how you could do it. This is how the child is looking like in his work. See, the sensory assessment starts from the very observation of the posture, because the posture is being contributed by the vestibular proprioceptive inputs as well. And the second is, you cannot assess sensory without giving the sensory stimulus. I have to give him a sensory stimulus, or a sensory experience rather. Let me correct myself, because sensory stimulus is again not a very good word as far as sensory integration theory is concerned. I'll have to take this child on a sensory equipment, apparatus, sensory experience has to be given, and then a response has to be seen at that time to be able to pinpoint on the sensory dysfunction.
Sir, as you said, all these stimulus it will give, then the result is poor. She doesn't respond to the sensory stimulus. So that is why we said here the sensory is more.
Did you see the ocular responses? Which yes, I do not mean vision. I do not mean vision. A test of vestibular system is the PRN, post-rotary nystagmus test. So if you could see the PRN, if you could see the modulation kind of activities and the response to the modulation activities. If you could see what's the most basic elicitable motor planning that you could see in this child, what's the tone of the muscles, what's the change of tone of the muscles when you give a vestibular stimulus.
So it
And if it
contracts.
is poor, and if it is poor, you could,
Yeah.
yeah.
Thank you so much,
Yeah.
Manish,
Thank you,
sir,
sir.
for
Thank
your
you, sir.
amazing presentation and very patient, like very calmly you interacted with everyone. So anyway, we have to keep up our timing part. So thank you so much, sir. Thank you so much for presentation.
Okay, thank you.
Yeah. Next presentation is by Dr. Sirin Idikulla. Madam, kindly switch on your video. Yeah, thank you so much. And Madam is a speech and language therapist who has been working for over 12 years with children with special needs. She finished her bachelor and master's from All India Institute of Speech and Hearing in Mysore, worked in Singapore for more than 2 years, and then started working in Bangalore way back in 2009. She has worked with Head Start Montessori School, FAME India, and now is the clinical director and trustee of Herein certified therapist for more than 2 words, and it takes 2 to talk programs, and has been trained on PECS prompt technique, brain gene and oral placement therapy level from 1 to 4. She is currently the only therapist in India who has completed her level 4 certification training in oral placement therapy. It is so wonderful to have you on board, ma'am. Welcome.
Thank you.
Can you share your screen?
All right. Thank you for inviting me for the talk. I will just share my screen. Give me a second. Is it visible? Can you see my screen? Yes? Okay.
Yes, it is. Yes.
Okay. Thank you. Okay. So a very good afternoon to all of you who decided to join us. Today I will be I'm like everyone's mostly OTs and PTs here. So today I'm coming in from a speech therapist point of view and trying to connect what you've been speaking about from morning. We had some fantastic presentations from morning about feeding, about neonatal care, etc. So I will be talking about the connection between feeding and speech development, especially in children with delays, and the kind of things that you would see. Okay. All right. So we all know that learning is a function of connections and interconnections that happen in the brain, and more connections, the more experiences we have, the more connections we have. So it's possible that when the child starts, feeding appropriately, those movement patterns can get transferred to speech, but at the same time, it need not occur automatically, but it relies a lot on the child's awareness of this connection. So if feeding is worked on without any exploration of modeling of sounds, anything of the sort, the child can still have an aha, oh, I can do this too. Oh, if I close my lips, I can make papa, baba, mom sounds. But it does not always happen that way. And that's what happens a lot with the children we work with, the children with delays. Okay. So I know feeding development was covered earlier by Dr. Geeta. So, I'm looking at it from a perspective from birth to 3 years. I'm not going to go into too much detail, but I just wanted to highlight a few things. So when the baby is born, the first job is to self-regulate for feeding, all right? And you have a lot of reflexes coming in, the rooting, the gag reflex, the phasic bite reflex, all of these reflexes that are really important for survival. The gag reflex is initially in the front of 1/3 of the tongue, okay? And then over time that starts moving back and back and back. Now the suck is non-dissociated. That means the jaw, the lips and the tongue, they all work as one unit. They are not separate. Now as the baby grows, 4 to 6 months, these oral skills become more active and more volitional rather than reflexive. Now, since they're becoming more volitional, the suck-swallow patterns are not very coordinated. right? So, and then by 6 months, 4 to 6 months, pediatricians will ask parents to get the child on to solid foods, semi-solid foods rather, like your posh chicken, ragi and things of the sort. So what happens, we have to start feeding them with a spoon. And that's when the child understands how to move their tongue a little bit more back and close their lips so that they can clear that food. Right? And what happens is the gag reflex starts moving backward, because only then the child will be able to swallow the food, take the spoon inside the mouth. So that's when automatically the gag reflex starts getting pulled back. Now, when you're looking at the next, you see, again, more and more fine-tuning of all these movements that are developing. You have more active movements from the lip, or more active movements from the tongue. You have a rhythmic bite or a munch-chew pattern that starts developing. And not a pattern that we have. It's not a chew per se, but still more of a munch and chew pattern. You'll see a lot of tongue protrusion right now, because the child is still trying to learn how to retract the tongue so that the swallow can happen. So there is a bit of a tongue thrust at that age, and that is very normal, just so that they can facilitate a swallow. And then towards 10 to 12 months is when the true sucking pattern forms. Till before that, it's more of a suckling pattern, but by 10 months, they learn how to suck from a straw, and that's the pattern that starts forming. And as you can see, more finer movements start developing, where they can, clear their lower lip with their teeth. There's a lot more coordination in the suck-swallow pattern. There is still a little bit of tongue protrusion when they swallow, but it gets better and better with age. The child also learns how to move his tongue from the midline to one side and the midline to the other side. And these are lateral movements of the tongue that slowly start developing. And then they learn to transfer food across the midline. Right? So as you can see, it's fine-tuning each time. As the child grows, there's a fine-tuning of development that happens. The jaws get more steady, there's more coordination, there's more independent movement, there's more tongue retraction, so there's a good control of liquid. There's, spillage is less. So all in all, more smoother tongue, lip, and jaw movements start developing. Now, why do we need to know this, right? Why do we need to know about how the development happens? Because we need to know that to understand what are the issues the children are facing. What kind of oral sensory or oromotor feeding disorders are they facing? Because even though there's no one-on-one ratio for speech production, there is a correlation between feeding and speech. And the movements that are created for feeding are similar to the movements that are needed for speech. So these pre-feeding activities that you do are very important for developing the feeding skills and speech production skills for children who have not acquired those skills. Just to give a simple example, you have the phasic bite reflex that happens in the first 3 months, right, from birth. Now, if a therapist goes in, a speech therapist or a OT or a physiotherapist who is trained to work with babies, goes in and kind of looks for that phasic bite reflex and there's no reflex, or there's going to be a high chance of that child developing motor dysfunction later. So that is where we can actually start helping the child with the movements that are necessary as a foundation for speech production as well as good feeding. All right. Now let's look at it in a gross way. How does this dissociation happen? Because I said initially everything works as one unit, and then slowly we are able to separate our muscle groups. And we have some dissociation. So it starts with the head from the body, it goes from jaw and head, lips, eyes, jaw, face, and then finally tongue from jaw, where you can go without having to move your head, without having to move your jaw at the same time. So it's not like you said the, la, but you say ta, da, la, with it only moving your tongue. So that's the kind of fine dissociation that needs to happen for both feeding and clarity of speech. Now let's look at in more finer detail in terms of the lip movements that develop and the tongue movements that develop. So as you can see, all of these movements develop based again on the neurotypical development of the child. So when a baby is born, what do? They have to feed. When they have to feed, they either latch onto the breast or the nipple bottle. So what do they need to learn how to do? Open their mouths from closed to open, right? Now, by 6 months or 4 to 6 months, as I said, when the spoon is introduced, what do they then need to learn? They need to go from open to close so that they can clear the spoon. So that's the first two movements that develop with the lip. After which, then they need to fine tune this, because it's not just about closing their lips around the spoon, but being able to take the food, for which they need to learn how to protrude their lips or move their lips forward, right? And then to take the food in, or when soft biting starts, soft chewing starts when they start taking the food inside their mouth, they need to retract their lips so that they have access to their premolars and all of that. So you have the lip retraction that happens, and when the child learns to start clearing their lip when there's food there, that's when lower lip retraction happens. Now, why am I saying all this? Because I will connect each of these movements to speech movements. Like I said, there's a correlation. It's not that it's a one-on-one ratio, but there is a correlation between these movements that happen. And similarly with the tongue, when you suckle from the breast or the nipple bottle, what's happening, that you have 50% retraction and protrusion that happens because the child has to take the milk in. And slowly, as the spoon is introduced, although protrusion is there, it reduces because the child needs to learn how to bring the food in, due to which the protrusion goes down to 25% and the retraction goes into 75%. Now, slowly, as the feeding, the complexity of the feeding increases, more and more fine movements start developing, where the tongue gets stabilized at the back of the mouth, and then it starts learning how to move laterally to each side, right? First it learns, like I mentioned earlier, from the center to the side, back to the center, center to the side, back to the center. Then as that develops and the child gets more confident in that movement, you have where the tongue can go across the midline. Okay, and then slowly, once that foundation is built, is when the child learns a proper swallow, because till then the child is still protruding his tongue to do a swallow. So as this stabilizes and the tongue starts staying in, and a proper swallow where the tongue goes up and takes the bolus of food back or the liquid back, and that's when you have the tongue tip elevating or going up, right, for the swallow. So this elevation and depression is something that starts developing. And then finally, we have the final movement, which is quite important for speech, which is called a back of tongue side spread, which is where the back of your tongue moves and it spreads there. And that's a really important movement for speech, and I'll tell you why. But as you can see, this is a neurotypical development of a child, right? And so we need to find out, where did it go wrong? What are the movements that are not there? And when you identify the movements that are not there, then you can correlate, okay, that's why that sound cannot be heard, okay? Now let's look at the connection between feeding and speech, looking at the neurotypical development. Like I said, close to open. So what is the sound that can come with that? For the J. If that movement is there, the child will be able to learn how to make those sounds. If open to close, when the child learns to do that, what's the kind of sounds that can come with that? Now when the child learns to protrude his lips to clear the spoon, if that movement is there, we can slowly start correlating these sounds, which is oo, o, w. Now when there's a retraction, we go into e, I. And then we have lower lip retraction, which is this, which is for f and v. And then you have a lower lip protrusion, which happens for sh, ch, j, r, and the American r, right? So again, these are all the lip movements, and you can see the corresponding sounds that come with these movements, right? Similarly, with the tongue, when you looked at retraction and protrusion, initially when it's 50-50, there's no sounds really that's associated with it. But if you notice children by 6 to 8 months, they will start going da 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 da, and everything is da 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 from there. That's because they are starting to stabilize their tongue at the back some more. And there's a little bit of protrusion, which is where the t and the come from. When the child learns to lateralizes tongue, there's no, again, no sound that's associated with it, but it is a foundation, like I said, to help with tongue tip elevation. And what are the sounds there? You get t, d, n, l, s, z, sh, ch, g, g, ng. All of these are the speech sounds that are associated with elevation and depression. All right. And then you have, like I said, the last movement, which is the most fine coordinated movement that's needed, which is your back of tongue side spread. This helps in something we call co-articulation. And that's the stability we need for co-articulation, is basically when we move from one sound to the other and move fast, and to maintain that clarity when we move from one sound to the other between words, in sentences. The tongue has to be so stable to allow us to have that kind of co-articulation. And that's why this movement of the tongue is quite necessary, right? Now, how is it all connected? You've had some presentations already about the sensory aspects and how it's connected to motor movements. The same way in our mouth, there is a big connection between the sensory and the motor and speech and feeding, right? So if you don't feel enough in your mouth, or you feel too much in your mouth, it's automatically going to affect the movements that you create. When you go to a dentist and you get an Novocaine injection and you feel all numb, you don't feel like you're talking really clearly, and that's because you don't get sensory feedback, right? You feel like you're slurring. You might be making movements, but you're not getting the feedback about it. So the sensory system is really important to be able to connect to the motor skills, the oral motor skills. Now, the oral motor skills are the motor movements that are developed with the jaw, with the lips, with the tongue, with the cheeks. All of these are really important to develop both the feeding skills, like I mentioned, all the feeding skills I need to develop, as well as the speech skills, right? And I connected the two also. So if you can see, there's nothing that's disconnected. Everything is connected together. So when you're looking at a feeding program as a feeding therapist, or if you're a speech therapist and working on feeding and speech, you need to look at all four systems and not just one or the other. You cannot directly probably go into speech without looking at the other systems. Similarly, if you're an OT and if you're working on feeding, you also need to work with a speech therapist to know, how do I convert that feeding movement into a probable speech movement, right? So there is a big connection, correlation, and we need to understand that it's all connected. So feeding and intelligible speech production will depend on the structure of the oral cavity. It will depend on the tone, the muscle tone, any associated medical conditions, the stability, not just in the body, but in your oral cavity too. The dissociation and grading of movements, that's the fine control movements that you get, and of course, sensory processing. So all of these 6 factors affect good feeding skills and good speech clarity, okay? So for all of this, to be able to get, what is it that a child or an individual, it could apply even to post-stroke, what is it that an individual needs to know? They need to have more awareness of the oral structures, such as the jaw, cheeks, lips, and tongue. They need to have that, oh, okay, I can feel my jaw, I can feel my lips, I can feel my tongue, right? They need to know where to place these specific articulators for specific functions. So if I need to move my food from one side to the other so I can chew on the other side, I need to have tongue lateralization and move it, right? If I need to swallow, I know I need to bring my tongue up and push the bolus of food back. If I need to make a curse sound, I need to know that I need to put the tip of my tongue down so that the back of my tongue goes up to make the curse sound. So it's a specific placement, and that's really important, because the minute the placement changes, the quality of the sound and the feeding skill also changes, right? Now, an example, if I were to say L, there's a particular way, and in Malayalam we have different types of L's, and in different Indian languages you have like variations of sounds. But if you look at L, the quality of the sound changes depending on the placement. So it's really important that children understand where exactly to place that particular articulator. Otherwise, we're going to have speech that sounds like this, because they really don't know what to do. And how specific to be. Dissociation grading, like I mentioned, those fine control movements, it's so important to have control in your oral cavity for a variety of things, meaning feeding and speech. If you don't have the control, it will be like what I just showed you, where I go, or I, and things like that. Instead of being able to say I, it will be I. That's because of the lack of control in your oral cavity, and that's really important too. Just like you need dissociation and graded movements in your body, the same way you need it in your oral cavity. There is no difference there, right? You need a lot of stability in the jaw. The jaw is not doing this all the time. You need a muscle endurance, because if I need to speak the whole day, I need to have enough endurance to be able to speak the whole day. Otherwise, what happens to all of us generally when we had a really physically tiring day, by the end of the day, you don't want to talk to anyone because you're just so tired. So for a child with a delay, or children that are young, if they do not build that muscle endurance little by little, they find it very difficult to maintain speech for a longer time, and they start going into just saying a word and stopping, 2 words max and stop, and you really can't improve their language further than that because they don't have the basic muscle endurance. Automaticity in movement is also really important. Speech, language, communication, all speech-based activities, they're all timed, they're coordinated, they're sequenced, right? Like how we walk, there is a timing, there's a coordination, there's a sequence of movements. The same way when we talk, there is so much of timing involved, there's a lot of coordination involved of the articulators, and there's a sequence of movements. And as you keep doing it, they become automatic, so we're able to talk fast like this. But that's what happens a lot of times with children with delays. This doesn't happen. All these 5 things that I just mentioned, somewhere there, or maybe for all of them, something goes off, and we need to identify where is it going off so that we can work on it. So what happens in children with delays? With respect to feeding, you'll have children with dysphagia, swallowing difficulties, choking, gagging, drooling, nutritional deficiencies, inadequate hydration. They will have limited types of food. There might not be adequate growth. They'll have prolonged feeding times. It could take an hour to finish half a chapati probably. It could take an hour and a half sometimes. Sometimes the parent is in the kitchen the whole time trying to find things that the child can eat. There will be a delay in the development of the feeding skills. There could be aspiration all the time, respiratory diseases recurrently. So these are some of the feeding difficulties that you can see. And some of the speech difficulties would be labored, effortful speech. You would have a difficulty in, making the sounds or prolonging sounds. That's it. They wouldn't be able to go, I want to go somewhere, or I want chocolate. This easy talking would be very difficult for them because they're not able to control their respiration and their production of sounds, right? They would probably have a lot of articulation issues. Either they might not be able to produce the sounds, or if they produce it, it would sound off. It wouldn't be clearly articulated. And if the misarticulations happen or the pronunciation goes off again, it does affect the clarity automatically. You might have children with a weak voice, a lack of loudness, poor control over the loudness, or loss of voice towards the end of the sentences and phrases, resulting in a whisper where I start like this, but this by the end of the sentence, right? Other speech difficulties could be a strained voice quality, breathiness in your voice, having a lot of the air wastage when you're trying to make sentences or short phrases. There's a lot of wastage of air, and you can hear that. Hypernasality, too much of nasality for sounds because of dysfunctions in the velar pharynx. They could have slow, jerky jaw movements. They could have a lot of disconnect, a lot of coordination issues. They could have drooling. So all of these things we see happen if those 6 things I talked about earlier don't work the way they're supposed to work. All right. And so how do the feeding disorders develop, right? What happens? So it starts with the physiology. So we had our speakers talk about neonates. We had them talk about what happens at that stage. Similarly, your premature babies, or if a baby has GERD, reflux disorder, or irritable bowel syndrome, it's just so many factors that can come in there. The physiology makes up a big share of what happens in the development later, right? So it could be underlying neurological issues, it could be chronic illness that's happening, multiple medical interventions. Maybe the child had to go onto a tube feeding, maybe there was a larynx issue and that they had to go. I've had children where one experience, traumatic experience, is enough to change the whole way the development happens. So physiology is a big factor there, which affects the motor skills. Because I'm not going to create the movements to eat, for example, right? If I've had a bad experience of choking, I'm going to be very careful the next time. So I'm probably not going, I'm going to just shut down in that process. And then you will see the child react every time you try to feed the child. And these then becomes learned behaviors, right? To avoid certain things becomes a learned behavior. And that goes on. And then what happens? Force feeding starts. And that again becomes a negative experience. But as a parent, you want to make sure that some nutrition goes in. So force feeding starts, and force feeding causes more negative experience. And it just becomes a vicious cycle. As you can see, the child's relationship with food gets affected. The family's relationship with food gets affected. When that gets affected, the family behavior gets affected. The family dynamics gets affected. And that comes back to the behavior, the relationship of the family as well as the child with food, right? So there is a vicious cycle that keeps going round and round, and we need to go in there and break it little by little, of course, without affecting the nutritional intake, but parallelly starting some things to help the child understand how to develop some motor skills that would help them with their feeding, right? But it is important to understand what kind of feeding disorder it is. If they have feeding issues, is it sensory based, is it behavioral, or is it anxiety based? And anxiety gets missed out a lot of times because it is taken as it's sensory. All right, and not always that it is sensory. It could be medical, for example, like GERD, reflux, that is causing these feeding disorders. It could be irritable bowel syndrome. It could be eosinophilic esophagitis that also causes these kind of things. So it could be a medical background. It could be trauma. So it's not always immediately it is sensory, but it led to a negative sensory experience, and hence things got affected. You also have children where it's purely anxiety. And so you will see similar reactions of, fighting the parent, not even bothered about food. I don't care whether you feed me or don't feed me. Not really having any interest towards food because, trying to, sometimes they talk so much, those especially with anxiety issues, when food comes in, they decide that's the time that they should talk about everything under the planet. These are some of the signs that we see where anxiety is the cause of the feeding disorder. Behavioral, whether it's behavioral or in terms of behavioral, mostly we will see where they are not particular about, like with the mother they might eat well, but with the father they won't. Or with the teacher they might eat well, or with the mother they won't. So if it's sensory, that would not be the case. It would be the same with whoever it was. So there are differences between sensory and behavioral kind of feeding that does come in also, and that we have to differentiate between the two. There could be some commonalities for sure. As you can see, the circles, they connect. So it's not one or the other, but we need to know, as professionals and parents also need to know, that there could be different aspects to those feeding issues, right? So as a speech therapist, when do we come in and how do we come in and what do we do to help? One thing I would tell all speech therapists is to please have enough knowledge. Please read up. Don't just go in there with the knowledge that you have from college, because it's just really not enough when you're dealing with young children. So please do read up and have the knowledge. The positioning, that's what we look at, the positioning of the child, and that has been spoken about so much over the presentations today. We help create more awareness of the oral structures. We start looking at the sensory difficulties of the child and making adjustments accordingly. We're also looking at all the sensory issues in terms of they do not like the look of the food, the texture of the food, the sound of the food when it is in my mouth, the temperature of the food, the presentation. Some of them will eat only in front of the iPad, the TV, the tablet, the phone, and will not eat otherwise, all of which will tell you that there is some underlying issue and we really need to look at it. We also kind of actively have to work on making the muscles of the mouth stronger and developing those fine coordinated movements that like I mentioned before. We're looking at getting the child to understand how to breathe while sucking and swallowing, of course, for babies. And that again has been spoken about earlier. We learn how to change, we teach parents, or we look at changing the food texture and liquid thickness to help them swallow safely. Because if they are choking or aspirating on thin liquids, and you do not want to keep giving them thick liquids, you want to figure out how we can thicken it a little so that they have the capability to swallow it slowly and manipulate it with the muscle strength that they have at that point of time, right? Teaching them how to chew foods, try out new foods and drinks, suck from a bottle, drink from a cup. These are all different movements that we would look at developing, getting more tongue movement, up, down, side, center, all of these, right? And of course, as SLPs would work on, getting more sound, more babbling, more controlled movements for different sounds, early communication, interaction, which is really important to build anything. Interaction is extremely important. And for those who are not able to get to speech, to start on alternative modes of communication and not to wait. And this is unfortunately something I see all the time, that there is a waiting period to start a child on alternative modes of communication. I would suggest please don't wait, because the more you wait, the more delay there is in the language development and the communication development. Don't wait for speech. If you know that there is a delay in the development of motor movements, please immediately try and get the child on an alternative mode of communication, because studies have shown, enough research has been done that show that starting them on alternative modes of communication help in the communication, in the speech development also. Right? It's not that speech is going to go away. It's not that you're not looking at as speech as an option. Yes, definitely you're working on it, but speech is a very complex motor act. It needs a lot of coordination, timing, etc. So you cannot wait for that to develop for 4 to 5 years without giving a child another mode of communication. And that's really important for all professionals to know, not just speech therapists, for the physiotherapists and occupational therapists too. Don't wait to provide alternative modes of communication or advising parents for the same, all right? It does not stop speech development. So when do SLPs start helping? Again, depending on the qualifications of the therapist, from NICU onwards, you can go in there. And that also has been covered by Dr. Geeta earlier. About the kind of things that can be done, from oral stimulation to identifying swallowing difficulties, finding the correct nipple for the bottle, for the rate of flow, helping the child latch on, stimulating the early speech and language development. That's important. Providing that education to the parents and helping them understand what they can do with their child to get more interaction from the babies, and to build a foundation for later. So what do we need to look out for? Definitely sensory processing difficulties, jaw movements, the symmetry in the jaw movement, the stability in the jaw movement, and the grading, meaning the control in the jaw movement. The same example, I can be say, that's because I don't have control over my jaw that I say that. And jaw movements control the vowels. Now, if the vowels are affected, 90% of your clarity automatically goes off. So it is really, really important that the babies, the children, toddlers, children develop those correct jaw movements. Of course, you're looking at the integration of the primitive reflexes, where the gag reflex is still not going on, the phasic bite reflex is still not going on for a long time, etc. So, it's really important. We're looking out for some abnormal atypical movement patterns, like, for example, where you have the tongue stays inside the mouth, stuck on the roof of the mouth, and doesn't really move at all. So you have this tongue retraction, you have tongue thrust, where the tongue is coming out, And you see this a lot with children with Down syndrome, especially children with spasticity. You see with cerebral palsy also that you see this. Another one, especially with children with cerebral palsy, that you see is cheek and lip retraction, which is when they look as if they're very happy and smiling and they're like this. They're always like this. This basically means that they have fixed their position into an abnormal pattern, and so as to compensate for the lack of control over their movement. So they fix it, and they always look at like they're smiling, but most of the time it's not. It's because of their lack of control. A symmetrical movement, if you ask a child to, stick out your tongue, because they're not able to maintain that symmetry. And why is symmetry important? Because speech is very symmetric, feeding is very symmetric. All right, you can't speak like this. The clarity goes up, so you need both sides to move symmetrically to be able to get good movements and good clarity in movement. Lip movements that we're looking for, tongue movements that we're looking for. So all of these. I'll just give you an example of what happens if there is, because I said the jaw is really important. I want to just highlight on this and what happens if there's jaw instability. So these are the kind of abnormal movement patterns that you could see. A slide where the jaw slides to the side, which happens a lot with children with very low tone, even with high tone. You can see this happen because they're not able to control. You have a jaw jut, is basically where the lower jaw moves forward. So you can see that it moves forward. That's a jaw jut. You have the child moving his entire head and body towards the spoon or the tool, like this, cannot sit and do this. We just use our lips, but they tend to move their entire body towards the tool. A high jaw fixed posture, where like this is a fixing. This is a fixing posture. This is high jaw. Low jaw posture, an open mouth. So when you have an open mouth, a low jaw posture, what's going to happen? The tongue is going to be more protruded. You're going to have drooling. Let's look at. You have poor lip closure, so hence performer gets affected. You have poor dissociation between the jaw, lips, and tongue, again, which affects clarity and development of more speech movements. With respect to feeding, you'll have drooling, water spillage, food spillage, messy eating, poor chewing, poor manipulation of food, preferring soft food all the time, inability to eat from a spoon, and hence poor nutrition. All right. Then, but when we look at, what do we do? What is it that we should do? We have to look at the stability of the body, which is really important. And so as a speech therapist, if you don't know what that means, please consult with your physiotherapist and occupational therapist to understand how to get that stability. It is really important to work in a team to understand all these things, because the more stability in the body that you have, the more mobility you have in your mouth, right? And these are just some of the things to get, especially for children who need, for example, constant movement. This move and sit cushion is quite useful. You have these Dyson sheets that you can get, you can cut and just put so that the child doesn't keep slipping off the seat or the feeding chair. You need a calm environment, and you need a way to help, again, organize their body. Again, for the speech therapists who don't know how to organize the body, please talk to your OTs and find out what needs to be done, because that's really important. Okay, so if there are sensory difficulties, you're definitely looking at working on it actively, both outside and inside, and you can work on it even with really young babies. Of course, you won't do everything. You will pick what can be done with the child and start stimulating the child little by little so that their awareness grows. The sensitivity can be controlled. It's not hypersensitive, that it can be normalized as fast as possible. Some of the other ways is to use taste, temperature, and texture, but again, not right in the beginning. You would slowly work towards that. All right, and these are just some massages that you can see that I've just shown. These are some of the tools that you can use, everyday tools that can be used outside, and these are tools that can be used inside the mouth. There are a whole lot of them available. Again, you will choose them based on the size of the oral cavity, the need. Please don't do this in random, because it does not help. Whatever you're working on, if you're doing sensory massages, you're doing it to develop a motor movement that's needed for feeding and speech, because these are the only two functional things that we do with our mouth. So we do not want to randomly massage the mouth just for the sake of creating an awareness. If you're creating awareness, create it towards speech movements, create it towards feeding movements that are necessary. All right. And if there are oromotor difficulties where the jaws are not moving, chewing is not happening, the lips are not closing, for example, or the tongue is not moving up to, have that defined swallow, we need to again work on that, as well as this endurance of the muscle, the memory, the muscle memory, all of that, right? So it's important to identify where the issue is and actively work towards it. And these are just some of the tools or activities that can be used. Again, not the end all. Again, completely dependent on the child and what the child needs, what you're working towards. So I'm just giving examples. This is not just, this is the only thing. So please don't mistake it that way. But these are just some things that can be used for children as young as 1.5 to 2 years of age, depending again on the other times. You can, when they don't have their teeth, you can use your finger brushes and get some movement going for, a munch-chew pattern and a chew pattern, etc. And when you come to feeding, you're looking at, because these are everyday things that happen. Spoon feeding, even if you're giving them semi-solid food, give them with a spoon. Now, if you can fine-tune that spoon feeding so that the child is able to actively move their lips and their tongue and their jaw, then that spoon feeding activity is a success. If you are just taking out and doing this and scraping the spoon against the upper lip, it's not going to help, because the child is not doing anything there. And only if the child learns to actively move his muscles will the next development happen. All right. So if you're looking at feeding, also you're looking at active participation, again based on the strength of the muscle and what else, the endurance of the muscle and all that the child can do, and the motor movements he has already developed. Drinking from a cup, sucking from a straw, all of these are creating movements. They're not creating speech. All right, because this is something that gets, there is a misunderstanding half the time that if I do oromotor activities, I get speech. If I do sensory activities, I get speech. No, you will not get speech. All right, sensory activities, doing massages alone will never get you speech. Doing oromotor activities on its own will never get you speech. It might stimulate the muscles, but it will not get you the speech that you're looking for. So it is one part of it. You need to connect them together. All right. So you are looking at, does the child have a sensory deficit? Does the child have a feeding deficit? Or does the child have a motor deficit, oral motor? Now, if there is, you need to work on it accordingly. If there isn't, okay, no problem. Same with feeding. If there is a feeding issue, make sure you implement those feeding activities so that it acts as a prerequisite for standard speech movements. If there's an oral motor deficit, you got to implement the program that helps create those motor movements. And if you don't have any of these things, then traditional speech therapy, where you're looking at the regular speech sound disorders, you can just work on it traditionally. But if that's not working and the motor movements are not there, then you have to look at whether it's sensory feeding or motor, what kind of deficit is there. So it's important, just to kind of summarize it all, it's really important to understand that feeding development acts as a precursor to normalize movements for speech production. There is no one-on-one ratio, but there is a correlation between the two. Oromotor movements are not to be done on its own. It must be converted into speech movements. Just because a child has lip closure does not mean he will automatically probably say "pervama," right? So do we need to actively work on it? Yes, that's where your speech therapists come in. Sensory processing affects those motor movements, and if the motor system gets affected, there will be physical changes that will happen in the oral cavity. An example would be if the child is not using his upper lip actively. Like I said, when you intend to do this, all parents do it. We take the spoon and we go, kind of scrape it against the upper lip, and the food is in the mouth. What happens is then that upper lip doesn't work at all. It's just sitting there passive. So what happens? The physical change happens when this upper lip will start moving up. So if that's moving up, it starts fixing in that position. What happens then once teeth start developing? the teeth will start protruding. The more the teeth protrude, the more the upper lip stays up. Now, what happens to the speech clarity? We go pa-ba-ma, and we are not able to say pa-ba-ma because this is completely inactive. So you need to work on all the systems in coordination. The reason I'm highlighting this is because a lot of times when I see children with cerebral palsy or other associated conditions, they come to me, say about 5, 6, 7, and I wonder why they didn't come earlier. So I have requests to all the professionals, OTs and PTs, speech therapists. Speech therapy is important from the get-go because we need to do a lot of motor work in the oral cavity to get that speech sounds out and to get interaction and to get early communication language and to get AAC in, right? So it's really important that you don't send the child really late for speech therapy. Just say, no, we'll work on this, and then go. I understand there's a lot of times that the child is medically unstable and they're very weak and they're not able to travel. That's fine. Then you're looking at a comprehensive program where you take inputs from a speech therapist and put it together. That's really important. Do not wait because that's that much time that's gone before the child has gotten adequate stimulation. All right, and that's it. Short and sweet. Thank you very much.
Thank you so much, ma'am, for
Thanks, madam.
very interactive and amazing presentation. So, anyone has any question, kindly unmute yourself and ask. How do we prevent drooling in CP children? That is a question for you, ma'am.
All right. Okay. So drooling, you have to look at why it's happening. Okay. So I said there are four components. You start with the sensory. Am I aware that my mouth is open? Am I aware that there's saliva pooling in my mouth? What is happening inside my mouth? You have no idea, right? So unless you create that awareness, the child will never realize that drooling is happening, and his mouth is always going to be wet. His t-shirts are going to be wet. Everything is going to be wet. So you're looking at, again, the sensory component and creating an awareness there, right? Then you're looking at the motor component and strengthening the muscles to make sure the mouth, the jaws can close. If the jaws can close, then the lips can close. If the lips can close, that means the saliva stays inside the mouth, and then it's about stimulating the swallow. So how do we prevent it? By working on that sensory and by working on the motor movements to strengthen the muscles to maintain that movement through the day. Okay?
Kindly unmute and ask the question. Ma'am, ready to take your question? Anyone?
Sir, I have to ask. Good afternoon, Shireen ma'am.
Good afternoon.
Hi. I have a question. How to prevent a trunk protrusion in a child who has a speech delay and sensory processing disorder, specifically tactile defensiveness. I have a child who has a tactile defensiveness and has a motor processing disorder with speech delay and tongue protrusion while doing a motor activity.
Okay. So when you have children with tongue protrusion and sensory processing difficulties, you always have to target the sensory first, because without the sensory, the motor is not going to change. So if you have someone who's tactile defensiveness, you cannot go in there and try to do movements. So the scenario could be that the child does not like you touching him. Then the goal is to get them comfortable, build that trust with them, let them know that you're not going to go inside their mouth right now. They need to trust you to know that they're safe with you. And if they do not trust you, you will not be able to do anything. I know a lot of times where therapists go straight in, the child is screaming his head off and there's massages happening. Not the way, because there is a negative experience associated with, and then you're not going to be able to do anything after that. So first you're going to target the tactile defensiveness and work on building that trust from extremities towards the mouth, not directly towards the mouth. So it could be just play. A lot of times I do like peekaboo with different textured cloth, and I just put it over their head so that they're just okay with that texture. And they say, oh, see, I see you. Oh, awesome, one more time. And just get some interaction going and some play going so that they feel, okay, this person is not going to harm me. And you will never work on it the first day, of course. And then slowly, as you build that trust to see whether, okay, do you think we can use this whistle? Do you want to touch it on your lip? No? Okay, let's touch it on your hand instead. We go 1, and I put on my hand. I put on your hand, I put on my hand. And work on that and work your way up towards touching the lips. If they are dead against it, you will start building a routine where you go, okay, I'm just going to do it once, and then my turn. You do it for me. Okay, I'm going to do it for you. Okay, you do it for me. And just working on that comfort level, step by step, till they allow you to go towards their mouth. So if you want to work on tongue thrust, that's a motor movement. You need to first have the child accept that touch, right? And only then can you work towards it. And if you are there, if the child is ready, you can work any movement that gets the lips moving forward, gets the tongue to go back. That is your blowing activities, blowing bubbles, blowing whistles, straw drinking, all of these. Any movement which needs tongue lateralization, whereas when you're chewing on the molars, it starts getting the tongue to move to the sides. Your chewy tubes also start stimulating. All of that start teaching the tongue to go back in and build that motor plan to pull it back in. So it's one step and then slowly towards the other step. I hope that answered your question.
Yes, yes, ma'am. Thank you so
There is
much.
a question for you, ma'am. What is your experience with kinesio taping around oral structures, mainly for swallowing or mouth closure?
I don't have any experience whatsoever with it. I have seen it happen, but I don't have the experience, so I can't comment about it. But it is something I have read about, but I have not done it. So.
Thank you so much, ma'am, for interactive session. Is there anybody who wants to speak?
Yeah, sir, yes, this is Varsha Venkatraman here.
Yes, Varsha, go ahead.
Yeah, Shireen ma'am, thank you for this wonderful session. My question to you is regarding the fact what you told, people come really late to a speech therapist by 4 to 5 years of age. So my question is whether when sometimes children are referred to physical therapist at 5 to 6 months of age when the delay is noted, any developmental delay is noted, in those initial, that is the from the age of 5 months to 1 year, what is it that we can check for, or how do we recognize, okay, now this child needs the help of a speech therapist, because that will help in is developing the feeding as well as further speech, and not wait till 2 years of age when we realize, okay, not even one syllable is uttered, so now the child requires speech therapist. So is that possible in that second 6 months of life that
Yes,
we can start?
absolutely, absolutely. We can start. Like I said, we get in there and even
What
at
is the
NICU time.
earliest we can start?
As I said, speech therapists can get in there at NICU time too, when they are neonates, when they're in ICUs also, because they start developing the reflexes that are necessary, right, for those who have not developed it. So you can go from there. But if you have a child who came to you, say, about 6 months, and because they're noticing motor difficulties, motor difficulties will not stop just like your trunk and your legs or your hands. It comes here too. There is very rarely a time when, I mean, I don't think there is a time when the motor part of the oromotor part is not affected. So the minute the oromotor part is affected, you are going to have feeding and speech issues. So if you start stimulation well in advance, you start preparing the muscles for more controlled movements later. Initially through feeding, and then slowly as the structures develop more and more, through other stimulation through speech production, like speech activities. Also interaction and getting the child to respond, because a lot of the times we see kids crying a lot of the times. They get used to one activity, but when they come to like a speech therapy activity, just crying throughout the whole thing because they don't know what's going to happen. And so insecure about everything. So, you know, to get them to understand that interaction is okay with everyone other than your mother too, or your father too, and to get comfortable with that process, you need to start young. Of course, like I said, it also depends on the child's medical stability and how much they can move around. But there is a lot that can be done. AAC is also something that can be done, you know, getting them to communicate in non-verbal ways first. So all of that can be looked at from the beginning.
Okay.
Thank you, ma'am. Yeah.
Ma'am, thanks for your timing and the wonderful presentation. The number of attendance remained 100% constant throughout your interaction.
Oh, lovely.
So, dear participants, we'll have a quick break of 5 minutes. Then after that, we'll have a Sundar sir interaction.
No, I think one more question is there from Mona Gupta.
Yeah, Divakar, please, Divakar sir. Please.
Okay.
In between, anyone has any doubts, please unmute and ask Sirin ma'am. She is available. Anyone in the 5 minutes break.
Hello, ma'am.
Yes.
Yeah, ma'am. I have seen elder kids who are otherwise normal, but they do sucking activity while sleeping unconsciously. So, what can be the reason and what can be done for that activities?
When you say sucking when they're sleeping, meaning they do the.
Right.
Is that what you mean?
Right.
It's a pacifier action. Basically, it's getting them to, because when you do that movement, you directly kind of activate your temporomandibular joint, and that's how why pacifiers work and bottle nipples work, and children breastfeed just to sleep, for example, because they get that stimulation here. Now, if they're doing it to sleep, probably again it's pacifying themselves to sleep. Now we have to then probably look at, are they getting enough input in the day? Are they getting adequate input to stimulate that TMJ? Can we give them in other ways that input through the day so that they don't seek it to sleep? And to kind of break a pattern, because by 6, 7, a pattern has formed. Breaking a pattern is always difficult, but you got to try and see if you can give them things to chew on, things to suck from a straw, twirly straws, more complex straws, so that they keep getting that stimulation at the temporomandibular joint, and so they don't seek it so much at the end of the night or in their sleep.
Ma'am, is it normal in elder kids also, like 7, 8 years old?
Generally not, no. That goes off by about, generally tends to go off once the baby's taken off bottle feeding, right, or breastfeeding, when that suckle pattern is going on. Basically, it's a suckle pattern that's coming back in, which is a primitive reflex. Basically, that's what's happening. So it's not really seen at that age. So
but ma'am, if it is there in normal child, otherwise if it's normal, but it is happening in an adult child, then what can be the reason and what can be done for that case?
That's what I'm saying, exactly what I said, where you're looking at, can you increase the amount of input he gets in his oral cavity through the day so that he doesn't seek that kind of stimulation when he's asleep? So can you start there and see whether that improves or breaks the pattern, right? Because I know children who were sucking their thumb till 2nd grade, 3rd grade, 4th grade, because it was a comfort. It's comfort.
Okay, thank you.
Hello, ma'am.
Yes.
Hello.
Hello, yes, go ahead.
Hello. Can you hear me?
Yeah, I can hear you.
Ma'am, if a baby of 6 months, some babies tend to have vomiting after burp. Some of the food come out of the mouth after burping. Will they have some speech problems after can you discuss about this, please?
Not necessarily that they would have, because by 4 to 6 months, what is happening is there is the gag reflex starts moving back further. So initially the gag reflex is here, then it goes there, then it goes towards the back, and that's why you have babies doing this, where their hands are in their mouth, and then parents say don't do that and put mittens on their hand. It's actually a very important process. They need to mouth, because as they mouth, they start pushing the gag reflex back further. All right, so you need to let them explore their mouth and do all of that. And I feel, again, I'm not sure, but you can keep monitoring, but generally it does reduce by 7 to 9 months. So you can keep an eye out for that, but it doesn't mean just because we have a gag reflex at 6 months that there is a problem, because they're still developing those movements.
Thank you, ma'am.
Any other questions?
Hello.
Yes.
Yeah, ma'am, I've already asked one, but I have one more question. Ma'am, you said that right from the birth, I mean, we can start the speech therapy intervention. But ma'am, what about the typically developing children? I mean, full-term born children. I have worked in a hospital where many times just after the birth, because of the flat nipples, many times mothers have to use nipple shields. Yeah, and so nipple shields, use of nipple shields, and many times it is not possible to feed a child at all because of the anatomical problem that a mother has to feed without a nipple shield. Does it contribute to poor development of a poor motor,
No,
oral motor skill?
no, not necessarily. Again,
Okay.
it depends on the skill of the child, right?
Okay.
If the child is not able to latch onto that nipple shield, or the bottle, if a bottle is used, right? If they're not able to form that suction, if they do not have the phasic bite reflex, these are concerns.
Okay.
Where you need to like, oh, okay, you know, something's happening. And most times when you don't have a phasic bite reflex, you will see that the child is having a motor coordination issue or neurological issue later. So you need to look out for these. Do they have a gag reflex? That's why these primitive are there.
Okay.
So you need to check out for these reflexes, make sure they're there, and the child is able to latch on, it's fine. So whether it's a nipple shield or bottle, it's fine as long as the child is getting the nutrition by latching on.
Yeah, okay. Thank you so much, ma'am.
Thank you so much for your amazing interaction and answering everyone very patiently. Next presenter is our Dr. Sundar, sir. Sir, please switch on your video. Yeah, thank you so much, sir. Sir has a topic of practical tools to implement early detection of cerebral palsy, evidence-based consensus. Sir has a long credential. He has 17 plus years experience in physical therapy, children with which treats children with neurological and developmental disabilities. Sundar